sebentar. Oke, udah di Zoom. Ada yang buka live call tag nggak? Udah live belum? Coba. Baru aku live-in tadi soalnya. Record nggak, Pak? Udah. Lu kemana? Tuh nggak ada.
Recording in progress.
Kayak dia tuh kayak takut yang nge-freeze itu. Baru 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 join baru grup IT seriusan. Tuh, gua kirim PC. Pertama opening sudah ngelemot emang. Coba pakai mahasiswa. Pertama pakai MC. Sini sampai gua. Nama itu siapa? Yang pembaca doa siapa? Ini nama zoomnya. Ganti nama jadi pembaca doa. Hah? Ya udah ngaji aja. Tilawah, udah bebas lah. Apa namanya, tilawah atau apa? Tilawah. Siapa?
Assalamualaikum warahmatullahi wabarakatuh.
Greetings of health and prosperity to us all. Salam sehat dan salam sejahtera untuk kita semua.
Alhamdulillahirabbil alamin. Wassalatu wassalamu ala asrofil anbiya'i wal mursalin wa ala alihi wa sahbihi ajmain. Amma ba'du. The Honorable, the Director of Poltekkes Kemenkes Banten, Mr. Dr. Dahrizal, SKP, MP.
We respect the Vice Director 1 of Poltekkes Kemenkes Banten, Mrs. Kusniawati Eskepnes MK.
We respect the Vice Director 2 of Poltekkes Kemenkes Banten, Mr. Sandy Cokro Wibowo, SN.
We respect the Vice Director 3 of Poltekkes Kemenkes Banten, Mrs. Asmawati SKP MK.
We respect the Head of Nursing Department of Poltekkes Kemenkes Banten, Mr. Parta Suhanda, SKP Embiomed IFM.
We respect the Secretary of Nursing Department of Poltekkes Kemenkes Banten, Mrs. Lailatul Fadila Eskepnes MK.
We respect the Head of Bachelor of Nursing Program and Nurse Program of Poltekkes Kemenkes Banten, Mrs. Haja Siti Waslia, Eskepners MK.
We respect the Head of Nursing Diploma Program of Poltekkes Kemenkes Banten, Mrs. Widya Sepalanita Eskepnes SPKMB.
We respect the heads of Student Affairs of Nursing Program, Mrs. Alif Nurul Rashida, SKEP Nurse, MKEP, SP, KEPKA.
We respect to our distinguished speakers, Dr. Nur Ajalina Sujianti Faisal PhD, Dr. Sigit Mulyono SKP MN, Dr. Joa Manuel Koresia Simenes, and Mrs. Luciana Sampe MKepnes SP Kepkom.
We respect DLMKM, BMKM, Poltekkes, Kemenkes Banten, and staff.
We respect the head of BPMJ and HMJ nursing program with staff.
And we respect all guests and participants in International Nursing Webinar 2026. All praise and thanks to our to Allah, the Lord of all the access. May the peace and blessing all of Allah be upon Muhammad, be upon him, the messenger of Allah, his family, companions, and who follow them in repentance until the day of judgment. Segala puji dan syukur hanya milik Allah, Tuhan yang semesta alam. Semoga salawat dan salam senantiasa tercurah kepada Nabi Muhammad SAW.
Tridharma sebagai pedoman kami, membangun hidup berdiri tak pernah henti untuk Indonesia tercinta. Poltekkes Kemenkes di Indonesia siap mengabdi nusa dan bangsa, berbudi luhur, berakhlak berbudaya, berbakti demi tugas mulia. Poltekkes Kemenkes di Indonesia bekerja profesional mendunia, semangat juang tak pernah padam untuk kesehatan bangsa. Siap melangkah untuk berbakti, Tridharma sebagai pedoman kami, membangun hidup berdiri tak pernah henti untuk Indonesia tercinta. Poltekkes Kemenkes hebat, Indonesia sehat. Kami insan negeri tercinta, penjaga kesehatan bangsa, menjunjung nilai-nilai kemanusiaan, berbudi luhur, berakhlak dan berbudaya. Kami Poltekkes Kemenkes Indonesia berjanji pada bangsa dan negara, bekerja profesional, berprestasi, melangkah bersama mandiri mendunia. Kami Poltekkes Kemenkes Indonesia berjanji pada bangsa dan negara,
2026 with the theme Advancing Cardiovascular Equity, a nursing call to action to community well-being. An important role in addressing this challenge through early detection, risk assessment, patient education, clinical care, and community engagement. This webinar is therefore an important opportunity to share knowledge, exchange experience, and strengthen international and interdisciplinary collaboration. We hope that today's discussion will generate new ideas, innovative approach, and evidence-based that can be applied in our respective healthcare settings to improve cardiovascular care and community well-being. On behalf of organizing committee, I would like to express our sincere appreciation to all distinguished speakers for sharing their expertise, to all participants for their enthusiasm, and to everyone who has contributed to making this webinar possible. Ladies and gentlemen, let us participate in this webinar with an open mind, a strong spirit of learning, and a commitment to turning knowledge into meaningful action. May this webinar strengthen our professional competencies and contribute to better healthcare and improve quality of life for our patients and communities. Finally, we wish you a fruitful and inspiring webinar. Thank you very much for your kind attention and participation. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you to Mrs. Nadia Zahara, Eskop Nurse MCOP, for delivering the report.
Terima kasih kepada saudari Nadia Sahara Eskernas Income yang telah menyampaikan laporannya. The fifth event, namely a speech by Op Nursing Department of Poltekkes Kemenkes will be delivered by Mr. Parta Suhanda, SKP Biomed IFM. The stage is yours.
Acara yang kelima, yaitu sambutan oleh Ketua Jurusan Keperawatan Poltekkes Kemenkes Banten, yang akan disampaikan oleh Bapak Parta Suhanda, SKP Biomed IFM. Kepadanya dipersilakan.
Thank you. Tes, dengar suara Bapak? Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Salam sejahtera untuk kita semua. Distinguished, respected speaker, college, lecturer, student, and all participants whom I highly respect. Yang saya hormati Direktur Poltekkes Kemenkes Banten, Bapak Darijal, Wakil Direktur 1, Wakil Direktur 2, Wakil Direktur 3, dan jajarannya, Sekretaris Jurusan, Bu Ella, Ketua Program Studi Dinas, Bu Eli, Kaprodi D3, Bu Widya, para narasumber, para akademisi, tenaga kesehatan, dosen, mahasiswa, serta seluruh peserta seminar internasional yang saya banggakan. First of all, let's us express our gratitude to Allah Subhanahu wa Ta'ala because by His grace and blessing we are able to gather today in this very important academic forum. Merupakan suatu kehormatan bagi saya mewakili jurusan keperawatan Poltekkes Kemenkes Banten untuk menyambut Bapak, Ibu, dan seluruh peserta dalam international seminar dengan tema Advancing Cardiovascular Equity, a Nursing Call to Action for Community Well-being. Tema ini sangat relevan dan dengan tantangan kesehatan saat ini. Ladies and gentlemen, cardiovascular disease remain one of the major global health challenge. Penyakit kardiovaskuler tidak hanya menjadi masalah klinis, tetapi juga berkaitan erat dengan health inequity and health inequity, yaitu adanya perbedaan kesempatan masyarakat dalam memperoleh informasi, pencegahan, deteksi dini, pengobatan, rehabilitasi, dan pelayanan kesehatan yang berkualitas. Dalam kondisi tersebut, nursing has a very strategic role. Perawat merupakan tenaga kesehatan yang berada paling dekat dengan pasien, keluarga, dan masyarakat. Nurses are not only caregiver, we are educator, advocate, research leader, and again, agent of change. Melalui health education, health promotion, cardiovascular risk screening, early detection, lifestyle modification, chronic disease management, rehabilitation, and community improvement, perawat dapat memberikan kontribusi nyata dalam mengurangi kesenjangan kesehatan kardiovaskuler. Hadirin yang saya hormati, the theme to today's seminar gives us a very clear message. Equity requires action. Kita tidak cukup hanya mengetahui bahwa masih terdapat senjangan dalam kesehatan kardiovaskuler. We have to move from awareness to action, from knowledge to implementation, and from research to real impact. Oleh karena itu, diperlukan kolaborasi yang kuat antara universitas, healthcare, institution, professional organization, government, researcher, nursing, student, and community. No single professional can solve this challenge alone. Collaboration is the key. Innovation is essential, and nursing leadership is critical. Dalam konteks pendidikan keperawatan, kita juga memiliki tanggung jawab untuk mempersiapkan future nurse yang tidak hanya kompeten secara klinis, tetapi juga mampu berpikir kritis, menggunakan evidence practice, memanfaatkan teknologi kesehatan, memahami social determinant of health, serta mampu memperdayakan masyarakat. Ladies and gentlemen, I hope this international seminar will not be merely a forum for sharing knowledge. I hope this seminar will become a platform for building collaboration, generation innovation, strengthening nursing leadership, and creating real action for our community. Mari kita jadikan seminar ini sebagai momentum untuk memperkuat komitmen bahwa every individual, every family, and every community deserves an equal opportunity to achieve cardiovascular health and well-being. Because ultimately, cardiovascular equity is not only about treating disease, it is about creating equal opportunity for people to live health and better life. Saya menyampaikan apresiasi atas dan terima kasih yang sebesar-besarnya kepada seluruh narasumber, para moderator, panitia, peserta, dan semua pihak yang telah mendukung terselenggaranya kegiatan ini. Thank you for your available presence, your knowledge, and your commitment to advancing cardiovascular health through nursing. Semoga kegiatan ini memberikan manfaat bagi pengembangan ilmu keperawatan, meningkatkan kualitas pendidikan dan pelayanan kesehatan, serta memberikan kontribusi nyata bagi masyarakat. Finally, with great enthusiasm and hope from meaningful collaboration, I officially welcome you to this international seminar. Dengan mengucapkan Bismillahirrahmanirrahim, Seminar Internasional Advancing Cardiovascular Equity, a Nursing Action for Community Wellbeing secara resmi saya nyatakan dibuka. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you to Mr. Farta Suhanda, SKP Biomed IFM, who has given a speech.
Terima kasih kepada Bapak Parta Suhanda, SKP Biomed IFM, yang telah memberikan sambutannya.
The next event is the presentation of the first topic, Innovating Public Health Service, Accelerating Global Development, and Ensuring Universal Access to Quality Care, by Dr. Nur Ajalina Sujianti Faisal, PhD, and moderate by Mrs. Agnes MKM. We now respectfully the stage is yours.
Acara selanjutnya yaitu penyampaian materi pertama, inovasi layanan kesehatan masyarakat, mempercepat pembangunan global dan menjamin akses universal terhadap pelayanan kesehatan yang berkualitas oleh Dr. Nur Azalina Suzianti Faisal, PhD, dan dimoderatori oleh Ibu Ani Fatmawati, Eskepners MKM. Dengan hormat kami persilahkan.
Thank you to the Master of Ceremony. Can I start it? Thank you to the Master of Ceremony for giving me this opportunity. Bismillahirrahmanirrahim. You can hear my voice? I'm sorry.
Yes, I can hear your voice clearly.
Okay, thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah. Allahumma salli ala Sayyidina Muhammad wa ala ali Sayyidina Muhammad. The Honorable Director of Poltekkes Kemenkes Banten, Dr. Dahrizal, SKP MPH, along with all distinguished leaders, lecturers, staff member, and the Civitas Academica of Poltekkes Kemenkes Banten. Our respect to the head of Nursing Department of Poltekkes Kemenkes Banten, Mr. Parta Suhanda, SKP in Biomed FM, and staff and community of the International Nursing Webinar 2026, all the speakers, and our respect speaker of today's session, Dr. Nur Azalina Suzianti Faisal, PhD. Thank you very much for your valuable time and willingness to share your knowledge and expertise with us. Thank you very much in this journal. And to all distinguished guests, colleagues, and participants of the International Nursing Webinar 2026. Welcome to this important event with the theme Innovating Public Health Services, Accelerating Global Development, and Ensuring Universal Access to Quality Care. Good morning, everyone. It is truly a pleasure to see all you joining us today. We hope that everyone is in a good condition. Before that, allow me to introduce myself. My name is Ani Fatmawati, and it's my great honor to be a moderator for today's session. For our first session today, we are honored to have Dr. Nur Azalina Suzianti Faisal, PhD, who will deliver. Excuse me, we can call you Dr. Azalina, is it okay?
Kan, boleh, bisa.
Bisa. We will Dr. Azalina will deliver a presentation titled Advancing Cardiovascular Equity in a Changing Climate, a nursing call to action for community well-being. We are honored to welcome Dr. Nur Azalina Suzianti Faisal, PhD, to our event. We sincerely appreciate her valuable knowledge and experience. Allow me to welcome our distinguished speaker with a traditional Indonesian rhythm verse known as pantun. Is it okay? Dr. Azalina, I have pantun for you.
Boleh.
Pergi ke taman memetik melati. Waduh, cakepnya mana ini?
Cakep.
Cakep. Harumnya semerbak di pagi hari.
Cakep.
Selamat datang, kami ucapkan sepenuh hati. Dr. Nur Azalina Suzianti Faisal, PhD, bersama kami di seminar ini. Oke ya, only one. Before we begin the presentation, allow me to briefly introduce our distinguished speaker by reading her curriculum vitae. Our speaker is Dr. Dr. Nur Azalina Suzianti Faisal, PhD, who currently serves as a head of Center for Climate Resilience and Strategy, MCREST, and senior lecturer in Management and Science University, or MSU. She has over 10 years of experience in the field of environmental health and science. Looking at her educational background, Dr. Nur Azalina Susianti Faisal, PhD, earned a degree in biomedicine from Management and Science University, or MSU, and further obtained a master degree from University Kebangsaan, Malaysia, and doctoral degree from University Putra, Malaysia. Throughout her impressive career, she has been recognized as a research group leader at Environmental and Occupational Health Club, INFOC, and has many published research findings that I have not mentioned it. Distinguished guests and participants, before we proceed, we would like to kindly remind everyone to pay close attention to the presentation. Please feel free to prepare your question, as we will have an interactive Q&A session, question and answer session, after the presentation. The presentation, Dr. Azalina, about 25 minutes, and the Q&A session about 10 minutes. Without further ado, let's warmly welcome Dr. Nur Azalina Susanti Faisal, PhD, to deliver her presentation. Please, Dr. Nur Azalina,
All right.
the floor is yours.
Thank you, moderator, for the brief, concise introductions. Good morning, Assalamualaikum, and greetings to everyone. First of all, thank you very much to the organizer for inviting me to be part of the International Nursing Webinar 2026. It's quite a pleasure to be here. I think we have nurses, we have academics, we have researchers, healthcare professionals, and colleges from different parts of the regions. I'm going to put up my slide, is it?
Panitia, please. Okay, thank you.
Okay, so today the presentation is entitled Advancing Cardiovascular Equity in a Changing Climate, a Nursing Call to Action for Community Wellbeing. When we talk about cardiovascular disease, normally we think about familiar risk factors, like example, hypertension, diabetes, smoking, obesity, physical inactivity, and unhealthy diets. Okay, but today I would like to broaden the discussions. I would like us to think about how our environment in which people live can influence the cardiovascular health. So we do have extreme heat, air pollution, haze. Now we have haze, flooding, food insecurity, and disruptions of healthcare service that can influence the cardiovascular risk. And very important, these environmental risks are not experienced equally. Some people have more exposure, some people are more vulnerable, and some people, they have fewer resources to protect themselves. So today talk, I will connect these three issues. First is the cardiovascular health, second is the climate change, and the third one is health equity. And most importantly, I want to discuss what nurses can do in terms of these changing climates and cardiovascular equity. Next slide, please. Second slide, please.
Panitia, next slide.
Okay, so before we begin, I would like to highlight the three things that I hope you will take away from this today's session. The first is understand. So we need to understand how cardiovascular risk, climate exposure, and health equity interacts. The second one is the second one is identify. So I want us to identify practical innovation that we can improve access, quality, efficiency, and continuity of care. And the third one is act. Because we understand the problem is not enough. As healthcare professional, we need to ask ourselves what we can actually do. What can we change in our clinical practice, and what can we do for our community? So how can we work with public health and environmental professional, and how we can advocate for policy that protect vulnerable population? So throughout this presentation, I will move from the problems to the evidence and mechanism, and finally to practical nursing actions. All right, so we will start with why cardiovascular disease should be viewed as equity issue. The next slide. Okay, so this slide gives us the starting point. We know that cardiovascular disease usually remain one of major challenges globally. So this slide, we highlighted the estimated 19.8 million cardiovascular death globally in 2020. So WHO Southeast Asian region mentioned there were more than 4.25 million cardiovascular death in 2021. What is particularly we concerned about is that 49.2% of regional cardiovascular death occur prematurely among people that age 30 to 69 years. So we are not talking about people in very old age. We are talking about people who are still working. Like nowadays, we raising family and contributed to their community. But one important message, or one things that we need to highlight, a significant amount of cardiovascular risk is preventable. Early detection, we can make a difference, and controlling blood pressure can also make a difference. Access to medicine can also make a difference. Healthy food, physical activity, and smoking cessation can make a difference. But we need to consider on our environments. So if a person live in an area that have high air pollution, experience extreme heat, cannot afford healthy food, or cannot access to healthcare, they can't really easily access to healthcare, their cardiovascular risk might be different. So therefore, prevention not only happen inside the hospital, it needs to be happen within the community, within the environment where people live and work. So that's why I describe cardiovascular disease as an equity issue. All right, next slide, please. Okay, equality is not equity. Okay, before we go further, we have to clarify the concept that very important throughout this presentation. Equity is not the same as equality is not the same as equity. Equality means everyone receive the same support. Equity means we adapt support according to the people needs, according to the exposure, vulnerability, and barrier. Let us take one simple example. Imagine that we provide exactly the same cardiovascular screening service to an urban community and remote island community. On paper, that one sounds fair, very fair, okay? But the remote community, they might have limited transportation, fewer healthcare workers, and limited access to pharmacies, and difficulty traveling to hospital rather than urban area. So providing exactly the same service does not necessarily create the same opportunity. So equity means recognize this difference and adapt the interventions. So throughout our cardiovascular program, we need to ask these 4 questions, a very important question: who is exposed? Siapa yang vulnerable, and who can access the protections and care, and finally who is left behind. So these 4 questions usually become part of how we design cardiovascular prevention. Next, please. Next, please.
Next slide.
All right. So we talk about Southeast Asia because Malaysia and Indonesia, we do have same location, geographic, and so on. So our region usually experience multiple change simultaneously. We have rapid urbanization like in Jakarta, and we do have in KL, and we have aging population, both country, Malaysia, Malaysia, Indonesia, Philippines, and so on. And we do have high rising burden of non-communicable disease. We have unequal access to healthcare, and we have increasing climate vulnerability, like we have El Nino, La Nina, and so on nowadays. So these factors do not operate independently. For example, rapid urbanization can be associated with sedentary lifestyle, traffic-related air pollution, and urban heat. And population aging means more people are living with hypertension, cardiovascular disease, and multiple chronic conditions. So at the same time, climate change is introducing additional stress to heat wave, floods, storm, haze, and food insecurity. And when climate event occur, healthcare service themselves can be disrupted. The clinics can be can become inaccessible, transport can become interrupted, medication supply can be delayed, sometimes we miss our follow-up appointments. So the cardiovascular challenge is not longer simply a disease management problem. It becomes one of health system problem, environmental problem, and equity problems. Next. So this slide show the pathway very clearly. We begin with climate hazards here. So as you can see, this include extreme heat, air pollution, haze, floods, storm, food and livelihood disruption, and healthcare disruptions. Then comes to exposure and disruptions. A person usually can experience heat stress, like they can inhale PM 2.5. They may displaced by flooding, or they may lost access to medication, or they may not be able to get healthcare facility. Then we have to see physiological and system effect. Heat can contribute to dehydration and cardiovascular strain. Air pollution can contribute to inflammation and oxidative stress. Disruption can result in delayed care and poor chronic disease control. And finally, we see cardiovascular outcome. So this can include usually hypertension, so IHD, ischemic heart disease, heart failure, and premature mortality. So the key message here, climate change can become a cardiovascular risk factor. And that means climate exposure should increasingly be parts of how we think about cardiovascular preventions. Next. So as you can see, we define the cardiovascular risk here. At the macro level, we do have environments, okay? We have change ambient temperature, change air quality across Southeast Asia. Then we do have micro level, which is the patients. So the patient has their own physiological characteristic, medical history, age, and existing cardiovascular risk. So, but connecting these two is the health system. So the health system usually need to translate the environmental information into practical actions. Like example, if we know that the extreme heat is expected, how do we identify high-risk cardiovascular patient? How do we communicate with them? How do we make sure that they have the medication? How do we make sure that they maintain the follow-up? And how do we work with community? So an ecological model means we don't look at the cardiovascular patient in isolation. We look at the patient, environment, and health system together. Next. Okay, as this slide focus usually specifically on heat. Okay, so as you can see, 88,450 deaths and 211,025 dailies in Asia in 2021 is associated with heart attributable heart disease. It shows increasing trajectory in heart attributable cardiovascular mortality and morbidity. This is very important because we know that heat exposure is become increasing relevant to country across the Asia. So the people who are most vulnerable include all the adults and people with existing cardiovascular conditions. And vulnerability become particularly important when people have limited ability to adapt. Like example, someone that usually work outdoors, live in poor ventilated house, no access to cooling, and has underlying cardiovascular disease may face several risks simultaneously. So heat should not simply be something we talk about during weather warning. Heat need to become part of one of cardiovascular risk assessment and preventions. Next. So what do we mean by cardiovascular equity? The first point is equity is not the same as equality, as mentioned. Second, cardiovascular health is strongly shaped by social conditions where someone live, their income, education, access to healthcare, and all matter. Third, cardiovascular risk usually is also shaped by the environment, air pollution, heat that influence the cardiovascular health. Fourth is climate change can widen up the existing inequality. People that already have experienced disadvantage may have fewer resources to protect themselves from additional environmental stress. And finally, we know that Malaysia and Indonesia provide useful example of different dimension of vulnerability. Both countries usually face climate and cardiovascular challenge, but our geography, our population distribution, our urbanization pattern, and healthcare access are different. So we need to have a solution that really in terms of the context sensitivity. Next. So this is explained before. Equity means we ask these four questions, okay? Exposed, vulnerable, access, protection, healthcare, and who is left behind. Next, please. Next, please. Okay, so social determinants of health. Cardiovascular risk does not begin when patient enter the hospital. It usually often begins much earlier. Okay, the first one is economic stability. Can someone afford healthy food? Can they afford transportation, medication? And second one is education and health literacy. Does that person understand the cardiovascular risk? Do they know what blood pressure means? And the third one is neighborhood and built environments. So we have to ask them either they have safe place to walk, exposed pollutions, is their home able to protect them from heat. So this factor influence the choice and opportunity available to individual. All right, next please. This is the three additional dimension of social determinants of health, food and nutrition. We know that healthy food is not simply a matter of knowledge, it's usually a matter of availability and affordability. Second is healthcare access quality, which we know that sometimes they usually cannot reach the healthcare system. And third one is social and community context, where social network, community organization, and local support can influence health. So when we talk about social and community context, this is where nurses have important advantage. We often have direct contact with patient and families. We heard about the challenge that may not appear in medical records, and the information that is extremely valuable to designing the equitable care. So next, please. Okay, so who is most vulnerable? Risk usually is shaped by exposure times susceptibility times capacity to adapt. Okay, we look at the groups like example, all the adults. Usually they have reduced physiological reserve and multiple health conditions, and people that are already living with cardiovascular disease may have serious consequences when exposed to heat or pollutions. And then low income household here, they have usually less access to cooling, healthy foods, transport, and healthcare. Outdoor or informal worker, we know they usually have high experience exposure to heat and air pollution. Rural, island, or remote community, usually this one they may experience longer travel times with greater disruption after climate event. And obviously, women, children, and caregiver, they have additional vulnerability related to household responsibility and access to service. So vulnerability is not one dimensional. A person may be vulnerable because of their health, and another usually can be vulnerable because of their occupation, and sometimes it can be where they live can be also vulnerable, and some people experience several vulnerability at the same times. Next. So we talk about innovation in public health looks like. Usually when we talk about innovation, we usually think about AI, because nowadays it's artificial intelligence, digital platform, or advanced medical technology. But innovation, it can be much simple. Innovation means how we find better way to reach, protect, and empower people. Like example, community-based screening, it can be bring us service closer to people. Digital health can support remote monitoring. Early warning system can connect the climate information with cardiovascular actions. Integrated care can combine cardiovascular assessment with climate vulnerability. And data for equity, usually this one can help to identify people who are being missed. So innovation is not necessarily we do need to have newest technology. Sometimes innovation is simply asking, can we deliver the same quality of care in a way that reach people who previously they do not have that access? All right, next. This is health challenge. Okay, so we see the 5 interconnected: the rapid urbanization, population aging, rising NCD burden, unequal access to healthcare, and climate vulnerability. So Malaysia and Indonesia usually Malaysia have experienced increased urbanization, heat and air pollution, concerned with the significant NCD burden. Meanwhile, Indonesia, they have large and geographical dispersion population. Indonesia have lots of many coastal and island community and that exposure to extreme weather and pollution. So vulnerability have different dimension. So regional collaboration between Malaysia and Indonesia is very important, but intervention must still be adapted to what our local reality is. Next. So this is comparison between the climate ratio across 4 Southeast Asia countries. Singapore, usually they have increased urban heat. Malaysia, like nowadays, we do have prolonged heat wave. Philippines, usually they have experienced severe humid heat and other climate hazard. And Indonesia, nowadays, they are face chronic tropical heat, high humidity, and air pollution. So the exact climate hazard may be different, but the health consequences can be overlaps. Okay, we know that heat can increase cardiovascular stress, air pollution can affect cardiovascular and respiratory health, flood and storm can disrupt the healthcare. So this is why we need to think about cardiovascular care as something that need to be resilient to environmental disruptions. Next. Next, please. Okay, so climate change as a health issue, this is one of key framework. Okay, so who is most exposed, who is most vulnerable, and who is at least capacity to adapt. So this is where the climate health become climate justice. So because the health effect of climate change are not distributed equally. All right, next. So his is excellent examples that nowadays we face it of why environmental health require collaborations. Okay, so this infographic you can see how smoke can originate from different process, including underground smoldering and incomplete combustions, and then contribute to a transboundary plumps. So this means that the committee experienced the health exposure may not be the committee that where the environmental sources originates. Okay, for CVD, the important issue is exposure. Okay, during this poor air quality episode, vulnerable people may need to reduce exposure and monitor these symptoms. So we require cooperation between health, environments, governments, and community. Next. So climate justice is closely connected with the health equity. So we need to ask ourselves who is exposed, who is vulnerable, who has the resources to adapt, and who is protected and who is left behind. Okay, adaptation should not simply focus on reducing environmental exposure. It should only focus on reducing the inequity that determines who can adapt. So this area usually nurses can play an important advocacy role here. Next. So this is PM 2.5. We go deeper than PM 10. Okay, so we know that environmental inhalation, fine particles enter respiratory system. So air pollution can have wider cardiovascular implication. So for nurses, this means that during period of poor air quality, cardiovascular patient need additional advice. You need to discuss on the exposure reductions. You need to monitor their symptoms. You need to identify their high risk individual, and we can communicate air quality information in a way that how they can understand. So that's why environmental information need to become a part of patient-centered care. Next. So 1% cascade means this one is how increase in ambient temperature can move to physiological and clinical pathway. So the body respond to physiological strain, usually reported 6% increase in CVD disease and subsequent hospitalization. So this pathway usually an annual increase in IHD and mortality across Asia. Next. So the hemodynamic engines of the heat stress heart is usually during heat stress, our body needs to release heat. So one response is increase the blood flow towards the skin. So when this happens, it creates additional cardiovascular demands. For a healthy individual, the body may compensate effectively, but someone with IHD or heart failure, cardiovascular reserve may already be limited lah. So the additional physiological demand can become significant. So we should ask them, are they working in extreme heat? Is their home have good ventilation, and do they have access to cooling? Are they able to maintain their treatment during extreme weather? So this question can become one of climate informed nursing assessment. Next. So this is the equity vulnerability section. We have biological risk. Okay, we do have occupational risk. We do have social risk. Okay, and usually this is the zone of critical intervention. This is equity-oriented care needed to identify people at the intersections and multiple risks. Next. So we go why nurses matter. Okay, nurses usually represent a major part of the healthcare workforce. We are trusted by the community. We develop long-term relationship with patient. Nurses present in hospital, primary care, community setting, workplace, and outreach programs. So we see the whole person. We don't only see the blood pressure. We may also see the patient family situation, occupation, living environment. So this usually means that we do meet things of community screening, health education, continuity of care, medication supports. So nursing has a very important position at the intersections of clinical care, community health, and climate actions. Next. So let me introduce you to the practical 4-step model. The first one is which we need to bring screening to people. So this usually can be mobile clinic, community center, school, workplace, or remote community. Next is screening. So we assess the blood pressure, glucose, BMI, waist circumference, smoking, physical activity, and cardiovascular history. The third one, we add climate here. So this is why this model become a bit different. We ask them about heat exposure. Okay, we ask them about air pollution and heat. We ask them about flood risk, housing and cooling, and medication access to during climate events. The fourth one is act. Okay, screening has no value if we simply measure and send the person back home. We need brief intervention, referral, medication review, follow-up, and community support. So the model is this 4 model is we add climate into the nurse-led cardiovascular screening model. Next. So this is the nursing role using 5 actions. Prevent, we promote healthy lifestyle and reduce cardiovascular risk. Prepare, we straighten up our community awareness. Like maybe we straighten up what is early warning for climate hazard. Protect, maybe we can deliver climate sensitivity and equitable care, like example for vulnerable groups. Partner, usually we work with committees. Sometimes we work with researchers, sometimes we work with government or other sectors and advocates. Usually we use our professional voice and evidence to support policy that can protect health and equity. So nurses are not simply responding to climate change. Nurses can become leaders in climate resilient healthcare. Next. So this is reaching undeserved community. So for rural and remote community, we may need outreach and mobile service. Okay, like example, coastal or island community, we need preparedness and alternative transportation arrangement. For low-income community, prevention and screening need to be affordable for them. And we do have migrants and mobile population. Communication between them need to be flexible and supported by the trusted intermediaries. And for informal and outdoor workers, screening should be connected with heat and pollution protections. So we should not expect vulnerable community to adapt to our healthcare system. Sometimes the healthcare system need to adapt the community itself. Next. So this is community health programs. Okay, we usually begin with screenings until measure. Okay, and then educate. We refer them to primary care or specialists, refer them follow-ups and measure. Next. So this is one of the community-based cardiovascular screening. Okay, so we identify the cardiovascular risk, and then the nurse will conduct the assessment. Okay, and then the nurse connect to the 4 model just now, the screen, educate, refer, and follow up, and then the nurse can become the bridge between these two lah. All right, next. So this is an example of community health programs that we did in Malaysia. So we include the climate risk. Okay, we include the heat, haze, and air pollution, flooding, food securities in the questions and so on. We ask them, and then we measure the 3 category of impact: clinical impact, equity impact, and climate resilience impact. Okay, so climate resilience impact, usually we care to continue during climate disruption. So this is quite important shift nowadays. We add the climate resilience, which how to make community healthier and more resilience. Next. Then nurses also can use digital health that can extend the nurse reach. Okay, is one of another opportunity. Remote monitoring usually can support blood pressure and glucose monitoring. We have to be careful. Sometimes technology can create another form of inequality if people do not have smartphone, internet access, or digital literacy. So we do have equity safeguard here. Usually we should offer during offline or community alternative. We should protect their privacy, and we should continue design the technology not only for digitally connecting population, where we know that technology should extend nursing reach. Okay, it will not replace the human connections because nurses is one of the middle important people in this. Next. Okay, so the how literacy is a cardiovascular intervention. Okay, so this is quite the health information that you need to understand what you can do and how we will support you afterwards lah. Next. So this is the building cardiovascular resilience hubs. So we are trying to do one hub where the center is active committee engagement. So the committee need to be involved in identify their own needs. So the center can be mobile health screening and committee cooling hubs and addressing the social determinants hub. Okay, so this model usually move from hospital center care towards the committee center resilience. Next. So green nursing initiative, we need to look at the environmental footprint of healthcare itself. Okay, national carbon footprint. The first area is resources optimization. We need to think about unnecessary resources use and sustainable supply chain. Second is climate resilient infrastructures. Healthcare facility need to be continue functioning during heat wave, flood and other climate event, and professional advocacy. Climate health science should become one part of nursing education, clinical decision making. So nurse that or not only respond to health consequences of climate change, we also need to contribute to reduce the environmental footprint of healthcare. Next. So leading with the heart, the future of cardiovascular resilience. First, this is the three major area of actions. First, we adapt the clinical practice. Second is we empower community. The third one is advocate for policy. So every patient, you have to remember that they have fair opportunity to achieve optimal cardiovascular health, regardless of where they live or the climate condition they have experienced. Next. So climate resilient cardiovascular care usually before event, we identify that high-risk patients lah, we as mentioned before. And then this usually before, during, after, and then this one usually create continuous cycles of prepare, respond, recover, and improve. That's why this thing makes how that healthcare is very resilient. Next. So from climate response to climate ready care, we need to prepare, we need risk map, high risk patient list, medicine continuity and staff training. Absorb means we need emergency communication, alternative service point and backup supply. Adapt, we need to have telehealth, flexible outreach and climate information protocols. And finally, recover. We have to restore follow-up, evaluate the gaps and improve the response. So resilience is not just about we survive the disaster. We usually need to have the system that can prepare, absorb, adapt, and recover while continuing to provide care. Next. So how will we know that innovation work? Okay, so usually when we look at this 5 area, we have to have access, quality, efficiency, continuity, and equity. So this equity is very important. So the means that we have to know that our program can reach thousands of people, but we will not fail to improve the equity if the most vulnerable people remain excluded. So the equity is we have to the gap narrow for high risk and undeserved population. So this is quite important aspects in the how we will to know the innovation work. Next. So what can nurses do next? This one is usually we start with tomorrow, and then we can ask ourselves these 3 routine assessment. I mean, when we ask patient, have you experienced significant heat exposure? Have you experienced air pollution or heat exposure? Can you assess your healthcare and medication during a climate hazard? Then you think about this in a year. Can we establish a committee pathway from screen to educate, to refer, to follow up, and measure the equity. And finally, together, we advocate for climate-informed cardiovascular prevention in our healthcare institution, community, and policy. So these three important message is that we don't have to wait for a perfect national program. Some change usually begin at us at the level of the clinic, at the level of committee, or level of nursing teams. So we start first, and maybe there will be a next perfect national program for the CVT and climate change. Next. So no single profession can deliver cardiovascular equity. Cardiovascular equity cannot be delivered by the nurses alone. So we need different sectors working together: nurses, primary care, public health, environmental professional, and most importantly is committee, because committee, they provide local knowledge, trust, and live experience. So this is why multidisciplinary collaboration is very important. So we need to move away from working in separate professional silo. Instead, we need to share pathway, because cardiovascular equity sit at the intersections of health, environments, and community. Next. So I will finish up the talk with 4 messages to take home. The first one is equity. Equity is usually who is exposed, vulnerable, protected, and who is left behind. The second one is prevention. So we need to move cardiovascular prevention closer to community. We don't wait until someone develops severe disease before we act. And third one is resilience. We prepare the continuity of care before climate hazard happen. When emergency happen, it's very late to start designing the system. And the fourth one is nursing leaderships. So we know that nurse can connect clinical care, community action, innovation, and policy. So nurses educate, nurses screen, nurses coordinate, nurses advocate, nurses can do research as well, and nurses can lead community action. So I would like to leave with one key message. Climate change is not environmental issue, it's cardiovascular issue, a health system issue, and equity issue. And nursing has a very important role in responding to all these three. All right, next. So thank you very much. If you are interested in continuing the discussion, collaborating on research, develop community-based, my contact information is shown on the slide. I'll be happy to continue the conversation and explore opportunity for collaboration. And thank you once again to the organizer and everyone that joined today. Thank you.
Thank you very much, Dr. Azli, for full and presentation. The interesting that I got, it's about climate justice is connected to the health equity. And the new knowledge that I got is, what is equity? Equity is who is exposure, who is vulnerable, who is accept protection and care, and who is the left behind. And also climate resilience and to the cardiovascular care before, during, caring after, and how learn how cardiovascular care. And another statement that I love it is from climate response to climate ready care. It's so inspiring for me. Okay, ladies and gentlemen, we have now reached the question and answer Q&A session. We invite participants who would like to ask questions to raise their hands or write down your question in the chat room. Before asking your question, please kindly introduce yourself and mention your institution. Is there anyone? Come on, raise your hand and open your camera. Silahkan yang mau bertanya. Silahkan mengetik di kolom chat. Anyone? Mungkin sudah paham rasanya ya, Dr. Azalina. Very powerful PowerPoint. and I love it. Everyone, you can raise your hand. Okay, from Hijrah Ramadhani, please. Hijrah, you can open your mic. Oh, we can hear your voice. Hijrah, you can unmute your speaker. Okay, please. Oh, maybe Adelia first. Hijrah first or Adelia? Hijrah? Okay, you can write down your question in the chat room. Maybe the second person, maybe Adelia first. Open your mic, Adelia. Or Ainul Salsa. Oh, the host not allowing participant to unmute themselves. Please, the committee. The host, please. The host. Oh, I can be the host. Okay. And yeah. Okay. I'm sorry. Okay. The host, please. I cannot unmute. Okay, just maybe you can write down your question in the chat room. Is it okay, Dr. Azalia? Okay. I'm the co-host, but I cannot unmute the participant or the. Hello, Adelia. Ainul Salsa.
Hello.
Okay, Alhamdulillah.
Okay. First, I want to thank for letting me. My name is Adelia Sucino Vitaliza, and Dr. Azalina. I want to ask, as we know, just a few days ago, forest fires in Kalimantan were new has that even crossed the border and affected part of Malaysia. And many people think that wildfire smoke mainly affected the lungs, only the lungs, but your presentation is highlighted that it can also increase cardiovascular risk. And building on that, my question is, why should be the main priority to protect vulnerable communities from cardiovascular complication during forest fire events, particularly in rural remote areas with limited access to healthcare. Thank you.
All right, thank you, Adelia. I think today also we do have this one today morning, our API in Selangor have quite increasing. You know the API, right? Air pollutant index, right? Okay, so you know the API, right? Air pollutant index.
Maybe
Okay, macam PM 2.5 dia ada satu air pollutant index that we usually think of this haze, how many air pollutants level that is not good, quite good for our country or for our regions. Okay, so usually this fire in Kalimantan usually, a bit part of Malaysia and Indonesia, where Kalimantan fire, the transboundary smoke haze and release PM 2.5 and other pollutants, and we inhale. So when we inhale, it goes to our system inflammation and vascular effects. So when we do inhale, it increase the cardiovascular stress. So people that have higher risk of cardiovascular symptoms or hospitalization event are particularly in vulnerable people. So WHO have already identified this PM 2.5, one of the principal public health threat from wildfire smoke. I mean, for the haze from Kalimantan and so on. And they already note that this wildfire smoke can cause or can exacerbate the heart disease. These fine particles, like mentioned in the slide before, PM 2.5, it can penetrate deep into our lung and enter the bloodstream and contribute to cardiovascular and cerebrovascular effect. So when you mentioned that why should we prioritize vulnerable community tadi kan, so we actually this terms is equity, where the equity arguments usually needs, we know that everyone is exposed to haze because everyone is not equally exposed, equally vulnerable or equally able to protect themselves. So we know that exposure is not similar to vulnerability, similar to adaptive capacity. So usually when these different things need to be differences, we need to know who is very vulnerable at times. So people that have chronic disease. So at this time, we have to know who is people that very adaptive capacity. So remote community deserve particular attention rather than urban community, because we know remote community, they can experience a convergence of exposure, vulnerability, and they have limited adaptive capacity. I hope it's answered your questions.
Yeah, thank you very much.
Thank you. I saw
The
they
next,
got 2 questions in the chat box,
yes,
right?
yes, from Siti Waslia, our
Okay.
lecturer.
Yeah.
What is the fundamental differences in heart disease prevention programs between Indonesia and Malaysia?
Okay. So for an Indonesia heart disease prevention programs, usually both Indonesia and Malaysia, they use same broad evidence base. We do primary prevention, hypertension or diabetes control, lifestyle intervention, primary healthcare and community screening. But how we organize that, organized delivery is quite different. Okay, so Malaysia is more towards clinic and risk management system oriented, but in Indonesia, I can see most of them are community network and insurance linked chronic care oriented, right? So usually the main strength of Malaysia is we do have systematic clinical risk management, and you guys quite good in community reach and chronic care engagements, because we know that our geographic area is not the same. Okay, so Malaysia, usually we already developed an enhanced primary healthcare model where we design around the population enrollment, risk profiling, integrated cardiovascular, and so on. So Malaysia, usually we identify, we risk stratify, we treat, we monitor, we refer, then we follow up. Okay, I think Indonesia, you guys have one platform we call Post-Bidu PTM. Betul tak?
Yes, Post-Bidu
Yeah.
PTM, and we have Cerdik and Germas
Betul. So
or NCDs.
ya, so itu
program.
dua perbezaan antara Malaysia dengan Indonesia lah.
Yes. Thank you, Miss Siti Waslia. Okay.
This one I know Salsabila.
Okay, thank you, Miss. Okay, thank you, Miss Siti Waslia. And the next question from Ainul Salsabila. Considering the current global situation, which cardiovascular health disparities being influenced by difference in healthcare access, socio-economic condition, lifestyle, and environmental factors, what do you think nurses can do differently to make cardiovascular care more equitable for vulnerable communities?
Okay, so thank you for the important questions. I think nurses can make cardiovascular care more equitable by changing where, how, and for whom we want to deliver these preventions. Okay, traditionally we often kita tunggu patient untuk datang ke klinik atau hospital. Tapi untuk vulnerable community, they usually face the greatest barrier to doing so. So I believe nurses need to move from clinic center care towards community center and climate informed care. So they usually do some differences. First, we reach people where they are. Okay, kita boleh bawa cardiovascular screening ke health education into rural community. And then second, we assess more than clinical risk. Usually kita assess, kita tengok berapa blood pressure, berapa dia punya diabetes, berapa kolesterol dia. Tapi mungkin kita boleh lebih tanya soalan, adakah dia pernah extreme heat, adakah dia exposed to heat or pollution, dia bekerja kat luar ke, kat dalam ke, they afford tak healthy food, and they access their medication and healthcare during flood ataupun any other climate events. Okay, then third, we prioritize people that have greatest vulnerability. Equity tak bermaksud does not mean giving everyone exactly the same intervention. It means that giving more targeted support to those that have greater exposure, greater vulnerability, and fewer resources to adapt. Then we have a lot of AI nowadays, technology. How we use our technology, telehealth, remote blood pressure monitoring. So we need to consider the digital divide. Technology should reduce inequity, not create another barrier. And usually nurses boleh jadi advocate, not only provider lah. We have unique position that we can see the patient, we can see the family, we can see the community. We can bring those lived experience into healthcare planning and policy. I hope it's answered the question. I know.
Yes, thank you very much, Doctor.
Alhamdulillah. And then the last question maybe Doctor. My name is Hijra Aramandani from Nursing Development 3, and my question is why is the aged population considered more vulnerable to climate change impact and health care disruption?
Okay, thank you, Hijrah, for these questions. So we know that aging population is more vulnerable to climate change because they are older adults. Usually they have less physiological capacity to adapt environmental stress. And usually when we talk about aging population, they usually have already live with chronic condition. Macam dia orang sudah ada cardiovascular disease, dia orang sudah ada mungkin risk of hypertension, risk of diabetes. Okay, so bila extreme heat berlaku, older adults usually they reduce ability untuk dia nak regulate dia punya body temperature. So bila panas, heat dia boleh increase the cardiovascular strain and may worsen existing heart condition. Okay, sama juga yang berlaku sekarang, air pollution dengan heat. Mungkin dia orang sudah ada heart or respiratory disease, dia orang sudah ada asthma. So that's one quite important problems in aging population. The second issue is sometimes for aging population, they have healthcare disruption. Dia ada problem in terms dia nak pergi healthcare, dia nak pergi klinik, nak pergi hospital. So bila ada banjir ke, bila ada heat wave ke, bila ada climate emergency, older adults usually they ada difficult untuk dia nak travel pergi klinik, dia nak dapatkan medication and so on. So this adalah interconnected vulnerability that we nurses need to help them. So we have to go to the committee. I hope you answer your questions.
Hijrah? Aging people not only from the climate change risk, but all the health risk condition dokter. Tidak hanya pada perubahan weather climate change, but in all health condition like infectious disease, it's the vulnerable population. Maybe from Hijrah, is it enough?
Oh, itu sudah balas.
Alhamdulillah. thank you for the response, Dr. Azalina, and for your valuable insight. In conclusion, I can say that climate change significantly impacts cardiovascular health. Not only cardiovascular health, I have read that diabetes mellitus also from the PM 2.5 with the extreme temperatures increase, not only from PM 2.5, with the extreme temperatures increase the incidence and mortality of conditions like ischemic heart disease, heart failure, stroke, and arrhythmias, especially among those with the existing heart condition. Nurses play essential role in preventing climate-related cardiovascular disease. They should identify vulnerable population, provide education on heat protection and air quality, promote healthy lifestyle, monitor risk factors, and recognize early warning signs. Additional nurses contribute to healthcare preparedness, particularly for elder adults and patients with heart condition, by collaborating with healthcare teams and communities to create healthier, climate resilient environment. The last you said that, sorry, I forgot that. Not only nurses, but all the healthcare team will have collaborating for the healthcare to the resilient environment, climate, and more healthy communities. Maybe that's once again we would like to express our deepest appreciation to Dr. Nur Azalina Suciyanti Faisal PhD for sharing your expertise and inspiring knowledge with us today. We hope that the insight gained from this session will provide valuable contribution to improving nursing practice, public health services, and global healthcare development. Thank you very much. And the next agenda is the presentation of certificates and documentation session. Maybe we would like to invite the organizing committee's member in charge to proceed with the next session. Panitia for the certificate. Or hello? When we talk about PM 2.5, Dr. Azalina, it is important to us as nurses, knowing the not only to into the body with the lung, but also it's a very risk factor for the hypertension also, and it's go to cardiovascular disease effect. So in my classmate, I'm in doctoral program in University of Indonesia now. Is it research from my friend about PM 2.5 that affect to the diabetes mellitus disease in Indonesia. So it's last night I looking for the information and I already knew about that. Thank you for your insightful today, and maybe it's not only for me but also for my student. Okay, committee, it's ready for the certificate. Hello. Okay. Maybe next sertifikat apakah sudah siap untuk ditampilkan, panitia? Oke, sudah. Kita masih menunggu rupanya Dr. Azalina.
Apa doktor? No problem.
Sorry, Miss, for
Yes.
certificate. Sorry, Miss, for certificate not display.
Okay.
Yang tidak ditampilkan, Miss.
Okay. Okay. Distinguished speakers, guests, and participants, as we conclude this session, I would like to take a moment to express my gratitude for your attention and participation. I sincerely apologize for any shortcomings I may have had during my role as moderator. Thank you once again, and I will now hand this
Sabar, gue
session
mau
back to
denger
the
anjir.
Master of Ceremony.
Oh, jadi kayak
Assalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Azalina.
Terima
It's a
kasih.
pleasure to have you.
Assalamualaikum.
Sampai jumpa. Please, MC. To the next agenda.
Thank you to Dr. Ajalina Sujanti Faisal, PhD, for your excellent presentation, and to Mrs. Ani Fatmawati, SKPNS NKM, for guiding the session with professionalism.
Terima kasih kepada Dr. Nur Azalina Suzianti Faisal, PhD, yang telah menyampaikan materinya dengan baik, serta kepada Ibu Ani Fatmawati, SKPNS MKM, yang telah memandu jalannya sesi dengan penuh profesionalisme. Please give applause to our speaker and moderator. The next event is the presentation of the second topic, intervention and simulation beyond programs, rethinking community cardiovascular activities in Indonesia LGP and AED in pediatric and adult by Dr. Sigit Mulyono, SKP MN, and moderatory by Mrs. Yunita Sari, MGEP SP Kepkop. We now respectfully, the stage is yours.
Acara selanjutnya yaitu penyampaian materi kedua, interpretasi dan simulasi melampaui program memikirkan kembali inisiatif kardiovaskular berbasis komunitas di Indonesia, RJP dan AED pada anak dan dewasa oleh Dr. Sigit Mulyono SKPMN dan dimoderatori oleh Ibu Yunita Sari MKepnes SP Kepkom. Dengan hormat, kami persilakan.
Okay, thank you for the Master of Ceremony for giving me this opportunity. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen, the Honorable, the Director of Poltekkes Kemenkes Banten, Mr. Dr. Dahrizal, SKPM PH, along with the entire staff and the academic community of Poltekkes Kemenkes Banten, whom I respect, to our distinguished speaker and all the participants joining us. And I hope you are in good health, high spirit, and ready to gain new insight from this session. Very warm welcome to international webinar. Let me introduce myself. My name is Yunita Sari, and I'm honored to be your moderator for this session. We have 4 speakers today, and there is one speaker. And in this session, we have Mr. Sigit. Sehat Pak Sigit. Assalamualaikum. Bagaimana kabarnya
Waalaikumsalam
Bapak?
warahmatullahi wabarakatuh. Damang. Sehat,
Ya, oke.
alhamdulillah. Good morning.
Alhamdulillah. Okay. Before we begin, please allow me to share a few brief of webinar. For the first one, please keep your microphone mute unless invited to speak to avoid background noise. And second one, from the question and answer session. We encourage an active discussion and feel free to write your question in the chat box anytime. Yeah, using the format name underscore in this institution and question. And before we begin the presentation, allow me to read the CV for our distinguished speaker, Mr. Sigit. Okay, we see the personal identity in the screen. From this background, we know that Dr. Sigit is a senior lecturer in the Department of Community Health Nursing at the Faculty of Nursing, Universitas Indonesia. He lives in Depok and he is originally from Ngawi. He earned from the educational and qualification background. He earned his bachelor's degree and doctorate in nursing from Universitas Indonesia and completed his Master of Nursing degree at Memorial University of Newfoundland, Canada. Okay, and from the experience, from the competency background, okay, next. We see that Mr. Sigit have a lot of experience in community health nursing, public health promotion, and disaster management. And he has served as an international technical assistant for WHO Sierra, led numerous national health research initiatives, and authored extensive publication on community empowerment and food safety and digital health application. Okay, next. And currently he serves as the manager of the Special Business Unit at the Faculty of Nursing Universitas Indonesia, as well as the head of the Services Department at the Indonesian National Nurses Association. Okay, today he will share his value insight with us. Without further ado, Dr. Sigit, the virtual floor is yours. You have 45 minutes. Please feel free to share your screen and begin your presentation. Okay, Mr. Sigit, you can share your screen or you need any help to share the screen. Okay.
Thank you very much, moderator, Dr. Anita, yeah, and give for brief introduction, and today also I say thanks to Mrs. Azalma yang every day they contact me to prepare this presentation. Actually today is my honorable that invite me to speak international webinar led by Poltekkes Banten. Actually, I ever come to Poltekkes Banten for a short time. I hope this moment can make continuous relationship between Poltekkes Banten and UNICEF Indonesia. As moderator explained that my background is a community nursing and supervise specialist community nursing student, and also every day I work as a trainee, organized training. Specifically BTTLS. BTTLS is basic training life support for nursing. So this is very relevant my job according this title, Interpretation and Simulation Beyond Program. I'm very happy, yeah, to discuss this topic, and also yeah, I would like to thank. This is very important for our community today because, as a previous speaker say, that cardiovascular now is the big problem. Not only problem of caring people with many diabetes and hypertension, but how much money the government pay for this disease? Yeah, uh, it's about more 80% or maybe 70% money pay for this disease. Yeah, this very very bad. Okay, I also would like to say hello to committee and also participant. I see that there is more 5,500 participant. Yeah, this is big seminar. Yeah, we can reach 500 participant. Okay, we see that uh, the cardiovascular is the big problem, and the important thing is how community caring, community care with this disease. Yeah. For the first slide, I explained that we have to recognize cardiac arrest, and also how we do starting CPR immediately, and also how we use AED, and also how we practice with the first time we have to simulate how to help people if we have a cardiac arrest in community. Next slide. Yeah. Why this material urgent for Indonesia? As a speaker before mentioned that cardiovascular disease remain the leading cause of death. Yeah, we know that over 25 million, global disease death because of CVD, and also we know that one stroke and heart disease among top cause of deaths in Indonesia. Yeah, the number one is the death because of CVD, and also the most money pay for it. Yeah, is below 10% time to access breath and respond. We have to do that. To saving life, we have to do very quick and smart under 10 seconds. And what is the Indonesian problem actually? The first is causalties are often not immediately recognized as a cardiac arrest because we have to educate people that it is a cardiac arrest exactly, and helper hesitate to start chest compression if we see people they lie down or because kayak model pingsan. Some people they still hesitate to start chest compression, and also uh, it is not yet available or does not know how to use it. Even though today AED we see on mall, most airport and everywhere, but do you think we can use if something happen with our friend family? This is a big problem. And also, one-time practice is not enough to maintain skill. You know that helping people with cause CVD by using AED is very skillful. Yeah. So, do you think as a community can we or as a health worker could we use this IED for helping people, community? This is our big question. You know that helping people with chronic CVD is we have a golden window rescue. 1 minute before we have to recognize call for help. Then 1 or 5 minutes we have to start CPR. And while we start CPR, please set up the IAD. IAD and CPR is they are different, but altogether very supportful for people with IAD. And then do less 10 minutes. So we have to early defibrillation by using IAD, and also we start emergency medical rescue. Yeah, we have to call EMS. We call. Next slide. Now, in title you say that beyond program. What does this mean beyond program? This is the committee is brilliant to use this idiom beyond program. According to helping people with CVD, we have to maintain kita harus mempertahankan betul-betul our community, our people, our government, even top government as well as local government. We have to focus on capacity building and develop infrastructure. What does it mean? Jadi beyond program bukan hanya program biasa yang sehari-hari orientasi pada program, tetapi betul-betul kita develop actual community to help with CVD. Also, kita juga bangun kemampuan kapasiti kita. Coba kita refleksi ourselves Apakah kita bisa membantu? Can we help people with is kita find people have a stroke, or people have a cardiac arrest, and also infrastructure. That means, do you think we can find easily tool or device can use to help the people, for example? Jadi capacity building is very important. The other thing is lainnya adalah embedding the core value of the initiative into the organization, mindset and daily habit until become natural part of the culture. Nah, ini adalah very important. Bagaimana kita membangun mindset dan culture pada all community bahwa keterampilan dan keinginan dan juga habit untuk bisa menolong masyarakat dengan masalah ini tuh benar-benar bisa dilakukan secara mandiri day by day life. Jadi sewaktu-waktu kita ada cardiac arrest. Nah, kadang-kadang kan kita melihat Pak Ustadz pada saat ceramah kemudian pingsan mendadak, itu the most is tidak tertolong. Biasanya didoakan saja, just pray God for God Tetapi we are as a health sebagai masyarakat yang memahami tentang penanganan pertolongan, harusnya itu bisa ditolong harusnya. Bagaimana kalau seorang Pak Ustadz lagi ceramah tiba-tiba jatuh pingsan? Tapi kadang-kadang kan tidak banyak hal yang kita lakukan. Seharusnya kita bangun infrastruktur di masjid. We build infrastruktur di masjid, dan kita juga harus bisa memanfaatkan alat itu untuk bisa menolong Pak Ustadz yang sedang cardiac arrest tadi. Akhirnya rata-rata hanya tinggal berita, diberitakan Ustadz yang lagi ceramah meninggal dunia. diceritakan Muslim yang sedang sembahyang meninggal mendadak, ya. Tapi nothing for help gitu ya. Oke, lanjut. Jadi beyond a program doesn't mean we have to set up community as a life, daily life. Lanjut, next. Nah, the preparedness gap. Why Indonesia need different approach? Ya, sorry I'm saying in bahasa Indonesia that make it clearly. As my experience, ya saya pernah tadi dalam CV saya pernah menjalankan pelatihan disaster management selama hampir 9 bulan ya di Australia, keliling seluruh provinsi ya. Nah, bagaimana negara maju itu men-set up bahwa pertolongan pada KRS itu benar-benar set up dengan baik ya. Kemudian di Thailand, saya juga pernah studi banding ke Thailand ya. Kemudian di Taipei ya. Dan juga di Indonesia. That way saya jelaskan sini, country with established system versus Indonesia konteks ya. Indonesia bukannya jelek, tetapi kalau kita bandingkan di negara maju, they are very different ya. Nah, apa yang saya dapat di sini, kalau di negara maju itu infrastrukturnya itu betul-betul ada dan benar-benar ada ahli yang bisa menerapkan itu dan melakukan itu. Tetapi negara maju dia kebijakannya berbeda dengan Indonesia karena infrastrukturnya bagus, SDM kesehatannya tersedia. Ya, jadi kalau ada kejadian secara ketek atau kejadian kecelakaan ya, itu rescue-nya itu secara otomatis akan hadir di bawah 3 menit ya. Nah, bagaimana dengan Indonesia? Misalkan ya ada kejadian KRS atau kejadian kecelakaan di jalan. Biasanya orang Indonesia kan terutama di jalan ya, itu kan tidak bisa membantu dengan cepat ya. Tapi memang di Indonesia diperbolehkan masyarakat jika mempunyai keahlian untuk bisa membantu menolong ya. Tetapi kalau di negara maju tidak boleh tuh. Ya, hanya mereka yang skillful di bawah 3 menit dia akan hadir dengan segera. Dan kalau tidak hadir 3 menit itu mendapatkan komplain itu ya. Nah, biasanya kalau di bawah 3 menit tidak ada medis yang datang, itu biasanya masyarakat langsung dia nimbrung, langsung dia di help ya. Tetapi dengan konstruksi yang sangat tinggi, artinya government akan kena penalti bahwa di bawah 3 menit dia tidak hadir menolong. Tapi kalau di Indonesia kebijakannya ya memang disediakan, tetapi kecepatan rescue itu tidak bisa serta-merta cepat hadir gitu ya. Sehingga saya cocok sekali dengan apa yang dituliskan di dalam seminar ini adalah beyond program. Ya, makanya melihat kondisi Indonesia seperti ini, makanya kita harus ya menyiapkan diri. If preparedness cannot rely on formal system, ya, jadi kalau rescue itu tidak bisa berjalan sebagai formal system di negara kita, how can community become ready themselves? Jadi bagaimana menciptakan community have to be ready untuk bisa menolong tadi ya. Jadi policy implementation are uneven, limited public AED access, perlu adanya episodic training dan juga community readiness failure. Jadi ya benar-benar community harus kita siapkan gitu ya. Nah, kalau di compare dengan negara maju sangat-sangat berbeda ya. Selain IT, teknologi dan infrastruktur itu sangat cepat sekali datang jika ada kejadian. Itulah berbedanya ya. Jadi melihat ini adalah penting dan banyak case-nya, makanya beyond program kita harus menyiapkan menjadi pembudayaan yang continuous agar all people Indonesia ready rescue gitu ya. Oke, thank you. Next. Why community from training recipient to learning community. Nah, inilah yang harus kita garap bahwa apa yang kita lihat out model government training community already done. But we have to propose model for next beyond beyond program. We have to establish community and train community by bahwa need for help people, need for help in any cardiac attack, because we have a high risk of people with cardiac arrest, hypertension, diabetes mellitus, and other disease already come from our community. So we have to learn, we have to practice, we have to simulate, and we have evaluated that our knowledge and skill improve or not. So community does not have always wait for formal training. Jadi community tidak harus menunggu training yang misalnya formal, tetapi community menjadi dibangun continuous learning environment. Jadi bagaimana kita membangun as a community nurse, kita harus bisa membangun environment yang kondusif untuk terus belajar agar sesama manusia, masyarakat bisa saling helper. Jadi sebagai contoh, bagaimana di masyarakat juga harus ada tanggap darurat. Sebenarnya program itu sudah ada. Tanggap darurat, ada mobil ambulan, ada klinik desa, ada koperasi desa, ada bidan desa, perawat desa. Tapi the big question is, apakah well trained, apakah ready, apakah sudah tested in any attack come, gitu ya. Kemudian di sekolah, ini di sekolah ini sebenarnya adalah area yang sangat cocok untuk kita membangun readiness untuk any people have cardiac arrest Nah, apalagi kampus, kampus, apalagi kampus kesehatan. Nah, ini juga big question. Apakah di Poltekkes adik-adik sekalian sudah tersedia AED? Saya yakin tersedia, ada di lab, gitu. Ada tersedia, ada di lorong kampus, Tetapi the problemnya, apakah kita skillful? Kalau ada kejadian kita bisa helper, gitu ya. Nah, ini di masjid tadi ini sayang sekali banyak sekali berita-berita Bapak Ustadz kita, penceramah kita kadang-kadang kecapean terjadi cardiac arrest, tetapi hanya tinggal kenangan tidak bisa tertolong. Tempat kerja dan juga public space. Nah, ini kalau di negara maju yang tadi saya ceritakan, setupnya sangat luar biasa, tersedia nakes yang terampil, dan ada panic button, dan ada otomatis alarm jika ada problem, dan dia akan datang before 3 menit. Kalau lebih 3 menit, itu akan dapat penalti dia. Artinya government akan dianggap tidak mampu. Ini yang bangun from training recipient to learning community. Community harus kita bangun untuk bisa menjaga herd kita, menjaga marwah nyawa kita, menjaga kita tetap life supportnya terus bersinambungan Oke, lanjut. Nah, chain of survival. Ini adalah chain survival dalam pertolongan gawat darurat dan juga community intervention point-nya seperti apa. Sebenarnya sih hanya 6 step yang kita lakukan bila kita ada cardiac arrest Kalau bila kita menemui orang yang pingsan, entah pingsannya itu karena gawat atau karena kena matahari atau benar-benar seriously cardiac arrest. Yang pertama adalah recognize and call for help. Ya. Nah, kadang-kadang ini canggung. Kita hanya melihat orang jatuh, gubrak, gitu ya, gubrak misalnya. Nah, kadang-kadang kita cuek, tetapi kita nanti akan menjadi tanggap. Ada orang jatuh. Ya, kita recognize, call for help. Begitu kita pegang, kita lihat napasnya, kita lihat denyut nadinya, kita tepuk-tepuk ya, call for help. Tolong, ada orang pingsan. Nah, baru kita langkah kedua adalah high quality CPR. Lakukan CPR. Ya. Nah, setelah CPR sambil kita siapkan AED, baru lakukan AED. Nah, AED ini nanti dia akan secara otomatis menganalisa detak jantung kita. Begitu detak jantung kita itu memerlukan defibrilasi, dia akan bicara, press button defibrillator dan dia akan defibrilasi. Nah, selanjutnya setelah detak jantung kembali, nah saya pernah pengalaman ini ya. Karena saya waktu itu sering jaga di gawat darurat, cipto dan di rumah sakit Islam ya. Saya berapa kali saya bisa mencoba untuk menggedor jantung ya. Kemudian dia survive lagi gitu ya. Nah, selanjutnya ini harus biasanya kalau orang sudah terbangun, sudah detaknya kembali, kita perlu adanya maintenance yang luar biasa ya. Akut life support ini benar-benar harus siap. Akut life support atau emergency medical services. Ya. Karena apa? Karena kalau sudah kita gedor dia bangun jantungnya, baru jantungnya ya. Belum tentu napasnya dia bernapas ya. Biasanya kan kalau lama cardiac arrest itu jantungnya berdetak dulu, kemudian baru napasnya kembali, baru berapa lama baru siuman gitu ya. Nah, makanya dia perlu advance life support dan juga emergency medical services di situ di tempat atau segera kita panggil ambulan. Baru post arrest care dan juga recovery. Nah, ini semuanya bisakah dibangun di community ya. Jadi education side of cardiac arrest and call CPR di training itu perlu dibuka di community. Public space, kita harus mulai mapping AED di mana, safety SOP di mana, real world and location simulation di mana, harus kita bangun ini. Nah, kemudian health services referral pathway, emergency medical system, event auditing and surveillance follow up. Nah, sebenarnya sistem kita di Indonesia itu kan modelnya sekarang adalah ILP ya, integrasi layanan primer. Ya sebenarnya sih di dalam program ILP ini ada program-program untuk layanan ini dimulai dari biasanya sih untuk prevention ya, jadi untuk cek kesehatan gratis. Itu maknanya luar biasa loh ya. Next slide. Next slide. Nah, community based cardiovascular intervention map. Nah, ini yang kita inginkan karena kita sayang nyawa, ya kita sayang kesehatan dan juga kita juga high risk untuk bisa mendapatkan masalah itu. Who knows ya, who know artinya belum tahu kita bahwa apakah diri kita juga high risk. Makanya kita perlu important ya CPR and IED to build ya, but it must be part of broader ecosystem or of prevention and wider more responsive system-nya. Tadi yang saya ceritakan bahwa kita harus bisa membangun ekosistem masyarakat yang bisa melayani kalau kita ada cardiac arrest. Ya. Nah, dan juga bagaimana membangun masyarakat yang responsif. Ya sebenarnya sih kalau tata kelola kita kaitan dengan integrasi layanan primer dan sudah mulai ada sistem education mulai dari puskesmas, kader, kemudian rukun tetangga, rukun warga, punya posyandu, posyandu, itu memungkinkan sekali ya untuk bisa mengembangkan community based cardiovascular intervention map sekaligus integrated dengan layanan cek kesehatan gratis gitu ya, bisa nih dibangun ya. Nah, kita harus bisa menguatkan risk factor screening melalui layanan cek kesehatan gratis di posyandu, pospindu, puskesmas, sekolah, dan juga ke perusahaan-perusahaan. Nah, baru kita bangun namanya Healthy Lives Promotion. Nah, para peserta seminar ya, para mahasiswa ya dan juga yang lainnya bahwa bagaimana kita membangun health lifestyle promotion. Nah, ini hanya masalah sepele, tetapi how to build routinely is very big problem. Ya, nah sebenarnya kan kenapa orang kena masalah jantung hipertensi yang membawa leading heart failure ya, cardiac vascular disease. The simple risk is dia makan tidak terprogram untuk low fat ya. Dia tidak biasa terprogram physical activity dan juga tidak bisa memanage emosional ya. Nah, sebenarnya itu simple 3 hal yang harus kita lakukan, tetapi very big problem ya. Kenapa? Karena keadaan Indonesia sekarang ini masyarakat sudah mulai terenakan naik motor ya, 100 meter naik motor ya. Harusnya sudah mulai di plan dan juga naik tangga ya. Naik tangga itu mudah sekali sebagai sarana prasarana untuk kita live healthy living ya. Jadi kalau kita di kantor ada tangga 1, 2, 3, lebih baik naik tangga itu dimulai dari lantai 3. Ya, kenapa? Karena kalau kita paksa ke lantai 3, itu kalau diukur kesehatannya akan lebih produktif gitu ya. Nah, selanjutnya adalah bagaimana community health rehabilitation-nya. Nah, ini biasanya mereka yang sudah terkena atau mulai sudah ada serangan atau sudah hypertension, ada kardiomegali, ya ini sudah ada community health rehabilitation. Baru kita juga menyiapkan public CPR dan AED, ya. Terus juga ada digital follow-up. Nah inilah yang terakhir karena di dalam era digital dan juga semua sudah terrecord dalam jaringan sistem digital reporting recording dari program ILP, harusnya semua ini bisa di record dengan baik ya. Nah mungkin saya bisa sharing ya, negara maju itu semua kejadian itu direcord di dalam file kesehatan ya. Sehingga tidak ada one missing, tidak ada missing sama sekali. Jadi the real time kita bisa lihat berapa kecelakaan hari ini, by government, local, and by top government. Ya. Berapa yang sakit TBC, today, early time. Itu bisa langsung di-connect kepada local, middle, top, Ministry of Health gitu ya. Ini dengan digitalnya. Nah, ini semua harus skillful train ya, bagaimana melakukan RGP, AED is a vital component but not the whole solution. Jadi community preparedness grow from prevention, response, and continuously support. Nah ini bisakah kita membangun ini? Sebenarnya sih jika bakal ILP ini sudah bisa mengawali semua layanan kesehatan itu tertata dengan sangat komprehensif, diawali dari see your health status ya, status kesehatan kita saat ini melalui cek sen gratis itu seperti apa. Nah, karena kebetulan saya juga saya juga di BPJS itu saya bidang kendali mutu dan kendali biaya ya. Apa yang dihasilkan dari cek kesehatan gratis itu fantastik ya, is very fantastic data dan big data. Apa yang kita lihat, ini saya by speech aja ya, ternyata ada 20 juta dari hasil pemeriksaan fisik itu kita terkena hipertensi. Dari 20 juta itu ternyata yang ditangani dengan sempurna hanya 2,7%. Bayangkan ya, dari 20 juta dari hasil cek kesehatan gratis kita sudah terkena hypertension dan DM. Dari sejumlah itu hanya 2,7% yang rutin kontrol. So, sisanya kemana? Nah, sisanya itu akan tersebar di masyarakat yang tidak dilakukan apa-apa. itu nanti akan terjadi ledakan yang namanya ledakan masalah kesehatan endingnya gitu ya. Baik, lanjut. Nah, ini adalah sangat kecil sekali ya. Inilah cerita tentang bagaimana melakukan CPR ya. Melakukan CPR kemudian diikuti oleh menggunakan AED ya. Nah, ini adalah skema yang bisa kita lakukannya. Lanjut dulu terlalu kecil ya. Nah, lanjut. Nah, ini adalah schematic how to do adult CPR, high quality cooperation and ID integration. Ini kebetulan karena saya melakukan training BTCS ya rutin ya, hampir tiap minggu saya keliling melakukan pelatihan BTCS ini dan hasilnya sih luar biasa ya kalau diterapkan dan masa ada itu luar biasa. Ya, jadi pertama kita lakukan compression kalau ada pasien tiba-tiba terdetak gitu ya. Kita cek nadi ya pernapasan, call for help, kemudian lakukan compression, kemudian lakukan compression deep ya untuk yang adult ya kalau bisa di bawah 10 scans ya. Nah, selanjutnya kita barengi dengan menggunakan AED ya, turn on the AED kemudian dipasang di dada dan AED ini akan secara otomatis akan mendetek irama jantung dan otomatis akan menganalisis irama jantung. Jika memang irama jantungnya itu biasanya ada bergetar atau henti jantung, dia akan instruksi lakukan defibrillator. Nah, baru kita harus clean area, baru kita panen button, dan akan terjadi shock, ya, defibrillation, biasanya jantungnya akan berdenyut kembali. Lanjut. Nah, bagaimana untuk pediatrik? Nah, sebenarnya prosedurnya sama, cuman untuk pediatrik itu karena sangat fragil ya, rentan ya, jadi menggunakan tangan ya. Gitu. Untuk adult adalah kita penolongnya adult adalah dengan menggunakan tangan tadi ya. Saya kira lanjut, ini hanya prosedur ya. Nah, ini clinical message-nya adalah if the children ventilation is more important because many cardiac arrests are predicted by respiratory failure. Jadi kalau anak-anak itu jarang ya terjadi cardiac arrest ya. Rata-rata cardiac arrest-nya karena telat pertolongan pernapasan. Ya, biasanya karena penyakit-penyakit pneumonia dan sebagainya. Ya, lanjut. Oh, lanjut. Lanjut lagi. Tadi yang ini lanjut. Nah, AED, when and how to use. Saya kira adik-adik mahasiswa yang lagi semester 1, 2, 3, 4 ya. Biasanya kalau nanti adik-adik sudah di akhir ya, biasanya mengikuti BTS. Tapi sebelum memulai itu, let me explain how we do AED, when and how is used. Ya. Jadi kalau seiring tadi dilakukan CPR, tidak ada respon, ya itu kita pasangkan ini ya namanya apa itu namanya katode ya kedua sisi jantung, kemudian nyalakan AED, dia akan menganalisis analyze ya heart rhythm, biasanya fibril dia bergetar atau tidak ada jantung gerakan atau yang sifatnya anomali, baru nanti apply the patch ya, do not touch ya, biasanya dia akan instruksi do not touch ya, baru shock mulai dilakukan ya, immediately rescue CPR. Nah, kemudian dilanjutkan dengan CPR ya gitu ya. Ya, next. Nah, keterampilan yang so complicated tadi dan penuh skillful, baik penggunaan melakukan CPR maupun AED, as a community kita harus bisa beyond program tadi, bagaimana kita juga bisa mengajarkan komunitas secara continuously tadi. Ya, every community can become learning model to build CPR and IED preparedness independently and continuously. Ya, jadi yang kita inginkan setup di negara kita yang banyak penduduknya dan juga fasilitas kesehatan yang terbatas ya, ada di daerah perkotaan dan rumah sakit itu pun juga terbatas ya. Mau nggak mau kita harus membangun preparedness ya di community secara kontinu di sekolah ya, di desa ya. Ini sebenarnya sih sudah dilakukan ya di sekolah, program kesehatan sekolah, di village terkait dengan program ambulan ya, klinik desa, perawat desa ya. Dan juga di tempat kerja sih biasanya dia sudah terprogram ya untuk bisa menyiapkan alat-alat kampus. Ini kampus harusnya tidak boleh missing. Nah, karena sih banyak sekali profesor ya. Nah, harusnya di kampus itu adalah aset yang sangat strategik. Ya, banyak orang pintar, banyak orang ingin belajar. Seharusnya kampus ini harusnya sebagai percontohan. Bagaimana kampus tiap lorong harus ada AED dan masyarakat kampusnya harus fully skill ya. Fully skill atau skillful untuk bisa menolong suatu kejadian keadaan aras tadi. Dan juga tempat-tempat ibadah ya, sehingga perlu adanya micro learning, skenario, simulation, feedback, dan repeat practice. Ini harus kita lakukan kalian ini ya, sehingga simulation is not only about the place, every place can become learner mode ya, gitu. Implikasinya bagaimana ya? Learning should not always wait for trainer to come. Community can learn immediately through micro-learning, simulation, feedback, and repetition. The problem is who to be leader, who to be teacher, who to be trainer. Ya, ini harus kita pikirkan atmosfer daripada community based in tadi. Jadi from lead trainer, kita harus membangun leading trainer, simulation, complete, become learner community, stimulated, dan affected. Dan ini harus repeat tiap hari. Ini harus katakan beyond program yang keahlian yang terakhir, yang harus kita repeat tadi ya. Oke, lanjut. Ini adalah who operate the ecosystem. Yang tadi yang my question is who operate the ecosystem. Kalau di kampus harusnya dean, kaprodi, ya, ketua kelas, ketua BEM. This is the leader of operation ecosystem as a campus. Ya. Who operate in the village must be head of dusun, head of lurah, ya. Ya, harusnya begitu. Ya, yang sebagai operate, ya. Sehingga kita harus bisa memerankan role shift of community nurses. Ya. Nah, thus as a community nurse, we have to be change agent. Ya, we have to role shift community training, gitu ya. Nah, sehingga key message adalah community learning system cannot rely on the single trainer, but on the ecosystem carefully designed, facilitate, and a quality assured. Assured ya, ada di sertifikasi ya. Di assured itu dipastikan. Lanjut. Community. Nah, lanjut. Nah, yang terakhir adalah dunia sekarang, dunia teknologi. Ya, apa yang mau kita planningkan untuk melatih masyarakat, melatih sekolah, musola, masjid, kemudian kantor-kantor, kampus-kampus, apalagi kampus-kampus yang non kesehatan itu harus menjadi pusat dari pengabdian masyarakat. Ya, nah di era sekarang teknologi is powerful. Nah, kira-kira siapa peserta yang sudah mendalami tentang teknologi AI. Nah, karena saya senang teknologi ya, karena problematik bagaimana membuat trainer itu murah dan bisa interaktif, ya, saya mulai mengembangkan teknologi VR simulation as a AI, robotik, ya. Jadi coba bayangkan bahwa zaman sekarang ini kita bisa latihan independen berbicara dengan AI dengan kayak model robot main catur gitu ya para sekalian. Ini hasil hasil riset saya terakhir itu eh, saya bermimpi bagaimana melakukan education eh, directly independent dengan berbicara pakai robotik yang sudah koneksi dengan AI ya. Jadi saya contohkan misalkan ada kasus bullying. Siapa yang akan menyelesaikan bullying? Nah, mau nggak mau kan orang tua atau guru kan. Nah, guru dihadapkan robot AI, dia bisa bicara, dia bisa marah, dia bisa responsif. Nah, kita harus bisa mengalahkan anak yang dibully tadi. Bagaimana menyelesaikan bully? Itu bisa di-develop dengan training simulation robotik plus AI tadi ya. Jadi, nah, alhasil testingnya, ternyata mereka yang guru-guru ya yang tidak mempunyai pemahaman bagaimana mengedukasi menyelesaikan masalah bullying itu sudah dimaki-maki sama robotnya yang dibully tadi gitu. Tetapi kalau seorang teachernya diedukasi tentang problem solving bullying, itu dia bisa mengalahkan robot dan robotnya akan mengikuti aturan-aturan untuk penyelesaian masalah bullying tadi. Gitu. Ini salah satu contoh ya. Jadi today technology is very advanced, so we have to use technology to treat our community. Ya bisa VR simulation, AI guide feedback, self fast learning, ataupun model video yang kita buat dan dicerna di community juga akan sangat lebih mudah ya. Jadi bring the simulation to community, not always to community to train center. Artinya eh, jika kita kembangkan teknologi education yang sangat-sangat baik, itu community akan bisa menikmati education itu dengan bijak dan juga dengan mudah ya. Baik, lanjut. Take homicide select reference. Nah, inilah tadi ending dari pembicaraan kita untuk bisa beyond program ya to reduce tadi mau nggak mau kita harus repeat interpretation stimulation will location more effective. It adapt sequence call for CPR ID. Community readiness require collaboration. The new AHA 2025 algorithm provide an uploaded clinical framework that should be adapted to Indonesian context. So, take home message, select reference, yeah. So we have to starting build community beyond program. So the community readiness, if any disaster, as a government, as an individual, as a family, we can adopt. Yeah, we can handle that problem. Thank you very much. Is that all for mine? Any question? Yeah.
Okay, thank you, Mr. Sigit. You have done the presentation. Okay, we have about 15 minutes to discuss. If any participant want to discuss, you can raise your hand and open your microphone to directly ask the question to the speaker, or you can write in the chat room. I see in the chat room we have one question ya Pak Sigit ya.
Yeah.
This is it is from Nur Hayati from Poltekkes Banten. The question is, what is your opinion regarding the urgency of addressing cardiac arrest in the community, particularly among lay people, including the importance of performing cardiopulmonary resuscitation or CPR and using an AAD, as well as increasing the availability of AED in public place, and in the future should CPR and AED training be incorporated into community education, either by being taught in schools or integrated into community health programs.
Yeah.
Okay, maybe you will answer the this question first,
Yeah.
or we
Thank you,
collect the
Nur
questions.
Hayati. This is is good question ya. What the urgency? Apa urgensinya? Nah, tadilah yang diceritakan speaker pertama dari Dr. Nur Azalina dan juga dari apa background saya. Konteks di Indonesia itu sangat urgensi. Kalau di negara maju itu setting hardware, facilities dan infrastruktur itu very very excellent ya. Karena apa? Karena tidak ada respon 3 menit itu sudah mendapatkan penalti untuk mendapatkan penalti hukuman gitu ya kalau tidak datang menolong ya. Bagaimana di Indonesia? Kita lihat ya case yang tadi saya ceritakan di masjid, ya di sekolah, bahkan di rumah sakit loh. Di rumah sakit itu ada yang dokter cardiac arrest itu meninggal, ya itu pertolongannya lambat itu, ya. Kemudian di community juga sering kan adanya cardiac arrest. Nah, selain database real kejadian, kita juga membaca analisis dari big problem. Kan dari hasil cek kesehatan gratis, ya kebetulan saya di BPJS ya, saya tim kendali mutu BPJS, terdeteksi 20 juta masyarakat yang hypertension NDM. Tetapi ternyata yang tertangani hanya 2,7%. So what? Sisanya itu kan hampir 97%. Nothing treatment ya. Itu akan berpotensi adanya very high risk. Dan we have to prepare, help them if any case. Entah dia cardiac arrest, entah dia jantung, entah dia apa. We have to rescue them. Jadi kalau urgensinya sangat urgent. So, karena tadi capacity layanan kesehatannya tidak tertata dengan baik ya, makanya kita juga community urgensinya harus bisa, harus belajar itu ya. Makanya kalau ada pelatihan BPJS untuk mahasiswa, saya yakin harusnya BPJS untuk para driver, para supir taksi, para polisi, bahkan polisi, para kena kondektur. Nah, saya pernah pengalaman naik bus malam, tiba-tiba ada anak kejang. Saya kan kaget, di atas ada apa, teriak-teriak. Begitu saya lihat, ibunya anaknya parah cuma ditekemin aja, diselimutin. Aduh, tolong loh. Kenapa begitu? Nggak ada yang bisa nolong. Akhirnya bayi itu saya coba untuk ibu, bisa nggak saya tolong gitu ya. Kemudian saya buka bajunya, kemudian karena ternyata panas tinggi, segera diresusitasi dengan cara mau dinginkan segera, dan akhirnya kejangnya bisa hilang. Nah, setelah tadi selesai ditangani, langsung busnya saya minta turun untuk di terminal dan nyari pelayanan kesehatan. Jadi urgennya luar biasa untuk community ready for help ya, gitu. Makasih. Ada lagi nggak yang missing guys? Apa lagi tadi ya? Nah, kan urgensi yang ditanya ya. What is the urgency? Ya, saya kira sudah ya. Among lay people including important performance lagi. Ya, CPR and AD training could incorporate with community education, either taught by school integrated into community health program. Nah, kalau yang mengajarkan harusnya adalah nurse atau dokter atau yang terlatih yang mengajarkan. Tetapi di area-area kampus, sekolah, pabrik, ya, community, tukang ojek itu harusnya. Nah, ini yang saya sharing juga ya. Saya waktu itu di Bandung ke Thailand. Kalau di Thailand kan puskesmas itu kan tidak melayani pelayanan ya, selain emergency. What they do just train community. Jadi go to community melatih. Jadi saya sambil gambar tuh perawat melatih driver-driver taksi itu dilatih itu, gitu tentang CPR gitu. Makasih.
Oke, baik Pak, terima kasih. Jadi dari apa yang sudah Bapak jelaskan tadi terkait dengan CPR dan AID ini eh, butuh untuk apa ya diinternalisasikan begitu ya Pak
Iya,
sebagai
iya,
bentuk preparedness ya terutama
iya,
di apa masyarakat kemudian di lingkungan sekolah begitu ya Pak ya.
iya, iya.
Oke, baik terima kasih Pak Sigit. Oke, is there any question? Maybe you want to ask directly with the speaker. You can raise your hand and open your microphone. Oke, ya. Sudah menjawab ya, Bu Nuri Hayati ya? Sudah ya? Oke. Oke, there is any question? Maybe? Ada yang raise hand kah? Tidak ada yang mau didiskusikan? Ini pengalaman Pak Sigit banyak sekali ini ya. Tadi di luar negeri, di Thailand tadi ya. Jadi Thailand betul-betul fokus pada promotif dan preventifnya begitu ya Pak ya. Tidak
Iya, betul.
puskesmasnya apa tadi yang kaitannya dengan emergensi tadi itu Pak.
Iya, iya. Ya kalau negara
Oke.
maju
Ada lagi yang
Taiwan.
mau
Ya.
didiskusikan?
Mm.
Tidak ada. Semua peserta sudah jelas terkait dengan apa yang tadi sudah dipaparkan. Tidak ada? Oke, sepertinya sudah jelas ya Pak ya. Baik, mungkin beberapa hal yang saya bisa simpulkan dari pemaparan yang tadi sudah diberikan oleh Pak Sigit. Yang pertama adalah kaitannya bahwa, oh oke, eh, a new question from Vini Azahra dari Valetehan.
Oh, iya.
Oh oke, oke. Di sini pertanyaannya adalah called community-based cardiovascular intervention unintentionally within health inequalities by primarily benefiting people who already have better health literacy and access to healthcare. If so, how can this risk be minimized? Bisakah community based cardiovascular intervention ini memberikan manfaat pada people who already have better health literacy gitu Pak. Monggo Pak Sigit.
Ya. Jadi apakah intervensi cardiovaskular beras komunitas ya tidak sengaja dapat dapat menyelesaikan ya masalah ini ya saya kira ini adalah salah satu alternatif ya. Salah satu alternatif yang harus kita lakukan mengingat urgensi tadi. Ya apa ya? Ya sarana prasarana sih pemerintah biasanya sudah menyediakan ya, tetapi kapasitinya kan kurang. Nah, capacity itu bisa karena jumlahnya alatnya, kemudian ready to use-nya, kemudian capacity how to use-nya, kemudian how to access-nya. Nah, sekarang permasalahannya misalkan, ya kita nyataan aja lah. Kalau misalkan di pasar tuh, kalau sekarang sih udah mulai ya, kalau di kereta kan udah mulai ada ya. Misalkan di pasar nih, tiba-tiba ada orang pingsan geletak gitu ya. Kita orang kesehatan nih. Kemudian kita lihat nanti ternyata dia nggak ada detak jantungnya gitu. Kemudian itulah kita lakukan CPR ya. Kita kalau mampu ya kita lakukan CPR. Tetapi begitu yang terjadi adalah biasanya kan kalau awal-awal kita lakukan CPR itu jantungnya berdetak, tapi berdetaknya kan biasanya nggak stabil. Ya, dia ada trailer atau apa nggak stabil kan kita butuh AED. Nah, begitu kita butuh AED, nyarinya gimana kita nyari AED? Ya, nah based on inequality tadi, makanya kita masyarakat harus mampu melanjutkan CPR, ya melanjutkan CPR sampai kita datang pertolongan, ya atau eh, apa ya, ya kalau memang ada fasilitas ya kita lakukan, kalau enggak kan kita CPR sampai ketemu pertolongan yang real real dari nakes gitu ya. Kalau menurut saya ini adalah nyata ya. Nyata artinya bisa dilakukan di community. Karena keterbatasan inequality tadi ya, keterbatasan sarana prasarana yang ada tadi gitu ya. Mungkin kita interaktif aja. Mungkin dari penanya pernah ada case nggak gitu, kenapa ini harus dilakukan, bisa bisa cerita nggak, mungkin barangkali punya case yang pernah lihat apa gitu ya. Ya sambil nanti bisa case contohnya aja lah. Kalau ada kecelakaan aja deh. Kalau ada kecelakaan kan orang kita cenderung untuk ngangkat dipindahin kan ya. Tapi itu kan justru terjadi the second disaster. Justru kalau ada kita kecelakaan jeger atau motor apa, itu kan harus kita lingkari, diamankan supaya tidak bergerak dulu. Dan lehernya juga kita pastikan dia terfiksasi. Tapi orang kita biasanya kan buru-buru ditolongnya adalah dipinggirkan itu kan takutnya kalau tulang lehernya tambah patah atau dia kalau ada fraktur dia tambah nusuk gitu ya, ada perdarahan tambah lebar perdarahannya. Jadi kan itulah kemampuan yang kita kita bangun ya. Sampai ada pertolongan datang atau enggak kita tolong, kalau misalkan patah tulang kita balut, kalau ada patah tulang atau kita curiga lehernya dia fraktur harus kita fiksasi kan. Nah fiksasi itu lah kemampuan kita. Kalau nggak ada fiksasi ini kan kita pakai sepatu diikat samping-samping kan bisa ya, kalau pakai sesuatu yang keras ya. Nah itulah kreativitas dari kita. Kalau kita ahli, biasanya pengalaman menolong orang dalam kebencanaan itu sesuatu apa yang ada di situ bisa dimanfaatkan. Spalek bisa kita pakai kayu, bambu, ya. Terus leher bisa pakai sepatu, bisa itu kanan kiri sepatu bisa tuh 2 biji itu ya dipertahankan sambil kita menunggu pertolongan gitu ya. Bagaimana? Nah,
Oke,
ini
bagaimana
semua ini semua harus di train, dilatih secara continually. Ya, pelatihan yang paling mudah adalah melalui sekolah dulu, melalui kampus dulu, melalui puskesmas dulu, melalui community gojek dulu kita kumpulin ya. How can this risk be minimized ya? Risiko itu kita minimalis kalau kita bisa latih ya, kita latih dia. Nah, makanya tadi saya ceritakan kalau di Thailand kan perawat tuh kerjanya keliling. Perawat puskesmas tuh keliling ke sekolah, keliling ke perkumpulan pemotor, perkumpulan driver, ke pabrik, apa itu keliling tuh melakukan edukasi. Kalau kita kan kebanyakan pasien di puskesmas ya, karena kita tuh sehari ada yang 3.000, ada yang 200. Jadi perawat-perawat puskesmas tuh kecapean dari pagi sampai sore dia hanya dalam gedung. Kapan dia keluar gedung? Ya belum ada waktu gitu. Harusnya itu adalah community puskesmas atau dilakukan oleh kampus-kampus yang mempunyai poltekkes ini dan stikes-stikes ya, dan juga UI juga ya. Kalau UI sih pengadilan masyarakatnya sekarang udah mengarah ke situ ya, sudah mengarah kepada pemberian ini pertolongan ya, dan juga edukasi tentang kesehatan. Di daerah-daerah eh, sudah ditentukan sih ya. Oh ini perlu ini, perlu ini, perlu ini, itu sudah ditentukan. Baik Ibu Moderator, terima kasih pertanyaannya bagus ya, luar biasa.
Baik Pak Sigit, terima kasih banyak atas jawabannya. Mungkin Mbak Vini Azahra, apakah sudah menjawab atau masih ada yang ingin didiskusikan
Mbak Vini dari Fatihah ya.
dari
Saya
Faletehan?
saya termasuk pengajar Fatihah dari tahun 94 loh. Pengajar secondary job. Ya, rumah saya di Falatehan ya. Ada Ibu Sri itu.
Istrinya
Ibu
aja
Sri,
Pak.
Ibu Sri Rahayu istri saya tuh. Saya di Falaten dari tahun 94 sampai sekarang dan saya tinggalnya di Serang. Ini lagi di Serang. Salam ya, Vini Azhara ya. Nanti ketemu di Falaten ya. Thank you. Your question is very good.
Oke. Oh, ini Pak, ada pertanyaan lanjutan Pak dari Mbak Vini Pak.
Iya. Ya Mbak Vini. Apa nih Mbak Vini? I would like to ask for follow-up question. Who can measure with the community-based first aid education actually lead to better outcome during real emergency rather than only measuring the number of people who are receive the training. Waduh, mantap nih ya. Nah, inilah PR kita ya, Mbak Vini ya. PR kita untuk memastikan bahwa universitas harus mampu membawa perubahan, ya, membawa perubahan ya. Nah, misalkan saja tentang gaya hidup ya, gaya hidup untuk fully menolong ya, menolong orang yang emergensi gitu ya. Ya, mulai dari, nah kalau di UI itu ada posyandu, posyandu kampus ya. Nah, jadi dimulailah dari warganya sendiri untuk bisa me mengakses dulu ya, untuk bisa melihat keberadaan kita kaitannya dengan kadar gula, kadar kolesterol, kadar asam urat, tensi, dan juga sekarang sudah mengarah kepada namanya adalah fitness, fitness ya. Nah, sekarang kalau di Valaten adakah fitness center, sport center? Nah, kalau di UI terbuka untuk para warga UI yang berminat untuk test center. Jadi nanti kalau kita mau sepakat test center, kita tuh dilihat kemampuan fitnessnya, dilihat kesehatannya, ada nggak berisiko gitu ya. Nah kalau dia oke, kalau dia bagus, dipertahankan, dia latih fitnessnya, flexibility-nya, endurance-nya, sama kemampuan kemampuan melakukan flexibility dan itu semuanya saya akan bilang ikut program 3 bulan itu. Nah itulah salah satu cara-cara ya untuk bisa bagaimana kampus menjadi apa ya, menjadi pusat perubahan, tidak hanya only apa outcome during real emergency rather than only measuring the number people ya receive the training ya, tetapi benar-benar adalah real ya, real. Jadi begitu siapa yang mau mendaftar ikut dalam program sport, program healthy, itu di-assess, ya, diukur, di-assess, kemudian Anda target apa yang Anda capai. Kalau berat badannya berlebihan, ya bagaimana mengukur berat badan. Kalau dia flexibility, endurance-nya, kekuatannya kurang, itu dilatih selama 3 bulan dan diajarkan. Nah, saya sampai dipoto terakhir skill saya di dalam melakukan hal itu dipoto, divideokan. Nah, itu menjadi pengalaman hidup untuk bisa ditularkan kepada orang lain. Ya gitu. Nah, kaitannya dengan pertolongan-pertolongan emergensi, Itu kalau di kampus kesehatan kita sediakan AED, ya. Karena di kami ada namanya mata ajar pengelolaan bencana. Di situ kita juga harus tanggap tentang emergensi, ya. Nah, saya termasuk di situ pengajar juga ya, pengajar emergensi. Nah, itu apa yang dilatihkan oleh student tentang penggunaan AED, ya kayaknya sih mudah-mudahan nggak ada kejadian, belum ada kejadian sih ya. Kita ada di rumah sakit ya, jadi langsung ada pertolongan dan dibawa koridor ke rumah sakit gitu. Nah, untuk Valatehan, bisakah Valatehan menjadi role model kampusnya yang mulai dari student, ya, mulai dari student dibentuk, kembangkan lokal penanganan cardiac arrest, nanti baru ditularkan ke sekolah-sekolah kelilingnya ya, pesantren kan di depannya ada pesantren tuh ya. Nah, saya dulu pernah itu education ke pesantren, pesantren depan kita tuh dulu waktu zamannya 94 itu kayak gubuk ya, kayak gubuk 2 meter kali 2 meter itu kita lakukan education untuk dia buka jendela, buka pintu gitu ya. Oke, itu ya bisa saya sampaikan. Thank you ya, questionnya dari Falatehan.
Oke, sudah terjawab ya Mbak Vini Azahra. Maybe it's the last question ya Pak ya. Kita sudah over time 6 menit ini. Oke, baik mungkin beberapa poin yang bisa saya sampaikan dari pemaparan yang sudah diberikan Pak Sigit tadi adalah kaitannya bahwa kardiovaskuler itu sampai dengan saat ini eh, dia menjadi leader cause dari kematian. Kemudian tadi sudah dipaparkan juga kaitannya dengan bagaimana golden window-nya 0 up to 1 minutes itu adalah fase recognize, kemudian less than 4 minutes itu start CPR and inisialisasi untuk AED, kemudian less than 10 minutes itu early untuk defibrilasi dan EMS. Kemudian butuh suatu kesiapsiagaan atau preparedness yang bisa dilakukan dari formal system dan juga dari segi komunitas gitu. Kalau dari formal system itu keterlibatan dari polisi, kemudian akses terhadap IED, kemudian dari segi komunitas itu kaitannya dengan sumber dayanya dan juga lokasi-lokasi yang bisa dilakukan intervensi terkait dengan hal tersebut. Kemudian tadi bagaimana membentuk suatu kesiapsiagaan tadi itu ya Pak ya, yaitu dengan suatu ekosistem yang memang dipersiapkan untuk bisa menghadapi kejadian kardiak arrest ya tidak hanya pada saat actual situation tetapi juga pada saat nanti untuk preventif, kemudian responsif dan juga continuous supportnya. Mungkin itu saja dari saya. Terima kasih banyak Pak Sigit atas insight-nya ya apa banyak ilmu yang bisa kami dapatkan dari siang hari ini. Mungkin jika Bapak ada yang pekerjaan yang ingin dilanjutkan, monggo boleh untuk melanjutkan aktivitas yang lain. Baik, untuk second speaker saya akhiri, saya kembalikan kepada MC. Terima kasih.
Terima kasih Ibu Moderator, luar biasa, Bu Anita. Dan terima kasih para partisipan yang luar biasa ya. Banyak pertanyaan yang bagus-bagus.
MC,
You to
okay, we will
Dr.
next
Sigit
to the
Mulyono,
agenda.
SKPMN, for your excellent presentation, and to Mrs. Yunita Sari, MKUP SP Kupkop, for wielding this session with professionalism.
Terima kasih kepada Dr. Sigit Mulyono SKPMN yang telah menyampaikan materinya dengan baik, serta kepada Ibu Yunita Sari MKUP SP Kepkom yang telah memandu jalannya sesi dengan penuh profesionalisme. Please give applause to our speaker and moderator. Next is the presentation of the third material, From Inequality to Access, Why Cardiovascular Care Still Fails Vulnerable Community, by Dr. Joao Manuel Soria Jimenez and moderated by Mrs. Afifa Nurmali Hidayah. I'm Deku. We now respectfully, the stage is yours.
Selanjutnya, yaitu penyampaian materi ketiga dan ketidaksetaraan menuju akses. Mengapa layanan kardiovaskular belum optimal bagi komunitas rentan oleh Dr. Jao Manuel Soria Jimenez dan dimoderatori oleh Ibu Afifah Nurmali Hidayah, AMD Kub. Dengan hormat, kami persilahkan.
All right, thank you, MC, for giving me this opportunity. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone, and also good afternoon for our speaker joining us from Timor-Leste, the Honorable the Director of Poltekkes Kemenkes Banten, Mr. Dr. Dahrizal, SKP MPH, along with the entire staff, lecturer, and the academic community of Poltekkes Kemenkes Banten, distinguish all of the guest speakers and participants in International Nursing Webinar 2026 with the theme Advancing Cardiovascular Equity, a nursing call to action for community well-being. First of all, let me introduce myself. My name is Afifa Nurmali Hidayah, and I have the honor of serving you as the moderator for this session. It is my great pleasure to welcome you to session 3 of our International Nursing Webinar 2026. In this session, we will talk about the material titled From Inequality to Access, Why Cardiovascular Care Still Fails Vulnerable Communities. This material will be delivered by our outstanding speaker, Mr. Dr. Joao Manuel Correa Jimenez from Timor-Leste. Hello, Mr. Joao. Good afternoon.
Halo, selamat siang, good afternoon. Greeting from Timor-Leste. I hope everyone is okay. And I hope that my voice is clear. You can hear me.
Yes, Mr. I can hear you clearly. Thank you so much for joining us to share your knowledge and experience. We extend our sincere gratitude for your time and expertise, Dr. Joao. All right, so before we listen to the presentation, I will first introduce our guest speaker by reading his CV. Okay, Mr. Dr. Joao Manuel Correa Jimenez is a lecturer in University of Delhi and also a general practitioner and focal point of pan and geriatric health at Malwa Health Post. He's a senior health system and CQI developer with over 10 years of experiences. He specializes in health policy development, health system strengthening, and NCD programs in primary healthcare. He has served in various leadership roles, including Head of National Program Unit for NCD, Head of Quality Control Department of National Health Institution, Head of Her Excellency Ministry of Health, Head of Department Ethics and Health Professionals Affairs. He obtains his master's degrees in public health from Nusa Cendana University, Indonesia in 2023 and medical doctor degree from Christian Maranatha University. He's also a certified trainer in CQI, PPI, HIV/AIDS, and COVID-19. So with his strong clinical experiences, especially in health system and NCD program in primary healthcare, I think that we can't wait to listen his wonderful talk about the topic today. Ladies and gentlemen, a little reminder during the presentation, please kindly ensure that your microphone is mute and the camera is on if you feel comfortable, and please pay close attention. Also, I encourage you to prepare questions for our Q&A session so we can have a lively and interactive discussion. All right, Mr. Joao, the presentation will be going for about 45 minutes and then following by the Q&A session for about 15 minutes.
So without further ado, let's begin our scientific sessions. Ladies and gentlemen, please warmly welcome our distinguished speaker, Mr. Dr. Joao Manuel Correa Jimenez, to deliver the presentation entitled From Inequality to Access, Why Cardiovascular Care Still Fails Vulnerable Communities. Mr. Joao, the screen now is yours.
Thank you so much. Before I start my presentation, first I would like to thank Poltekkes Banten for the very beautiful opportunity for us from Timor-Leste, especially from Deal University, and for me that have the opportunity to share and to learn of something about the cardiovascular disease and why it still remains our main problem to tackle the issue, especially in the relevant with the equity in access for this CVD services. So before I start the presentation, I would like ask help from the moderator to share my presentation because I have some issue with the internet from here. So I hope you will help me with the sharing my presentation from there. Thank you so much. And because of the internet issue, maybe it's better for me to not to turn on the camera because I would like to my presentation go smoothly, so not interfere with the connection issue. So if you can allow me to do this, and I will be very, very grateful. Thank you so much. And maybe in some explanation, I will just use Indonesian language because for me it's better rather than to speak in English. Thank you so much.
All right, Mr.
Okay. Okay, thank you. First of all, once again, I want to thank everyone. Good morning to all the participants, all the CEO from the Banten, Poltekkes Banten, for this very good opportunity for me. Today, I will share with you the problem that still remain why cardiovascular disease still become the main problem, especially for the vulnerable communities to access. So next. So in the presentation, we will talk just briefly introduction about what is the cardiovascular disease and its burdens, and also the major disparity why inequitable happens related to these cardiovascular disease services, and the root factor that caused the service not happen properly, and also what the impact of the inequity for this specific disease. And I will bring you just briefly to the Timor-Leste context, and also I will come to the share how as a nurse students, as a nurse, or maybe as a health professional care, we can tackle this problem together as a policy, as a strategy, and also in the practical ways. Okay, next. So before I start, I would like to thank these two speakers previously that already delivered the good material, good presentation, good information for all of us here, including me, especially Dr. Sigit. Specifically deal with the clinical issue, how to tackle cardiac problem. So I will not go to this clinical issue deeper in that, but just focus on the public health issue, and also how nurse can intervene if the situation occurs in front of us. So this is the introduction. So as we see, the data shows that it's become CVDs is still the main problem for us globally. 19.8 million CVD deaths occur based on data in 2022. So 32% of all global deaths, and more than 75% of CVD deaths occur in the low middle country income country. So like Timor-Leste, maybe other country from the part of Africa. So this is become situation is our real problem for us in our country. So the gap also show that there is a gap between in rural and urban area to tackle the issue. From 2024, a systematic review meta-analysis shows that more than 39.5 million patients found higher follow-up mortality among rural patients. So there's a big difference between urban and rural area when we talk about the cardiovascular disease. And also the gender-related disparities also happen, especially country like Timor-Leste, when we put women just in home, and maybe it seems like they become a second class of our society. So it's very difficult for them to access the health services, including the cardiovascular disease services. And also data shows that in 44 lower middle income countries, the improving hypertension diagnosis and treatment as a cure, and then produce large absolute CVD benefit among lower wealth groups. So we compare to the advanced country, CVD has become very big problem in the LMIC's country. Next slide. So just briefly, I don't want to talk this to focus on this, but I just emphasize the red written in the red letter for my friend nursing students that CVD, cardiovascular disease prevention, begins before the patient reaches the hospital. It's more important, very important for us to tackle, because once it's happened, and then it's become very hard for us to deal with this CVD problem. So it's very good for us to prepare, as Dr. Sigit said, that we put patient and also community. We go to them and we start very soon to prevent, rather than let them come to hospital once they get sick. Next. So the global factor CVD risk profile, I think we all know it depends. It's related to the behavioral, metabolic, and also environmental, our environmental system. So it's very important for us, and it's quite easy. That's why WHO emphasized that many premature CVDs deaths can be prevented So through the risk factor reduction and appropriate treatment. So we are expected to intervene in the risk factor rather than we intervene in the curative process. Next slide. From the WHO, we learned that, and also the real situation, we learned that hypertension is root cause, main cause of all the CVD's problem, and also its complication. That's why, and it's quite easy to deal with hypertension rather than the other condition in CVD's problem. So we focus on the hypertension, and then we can, at least we can solve many problems related to the CVD's problem. The paradox is we know how to detect and treat hypertension, but million remains undiagnosed or uncontrolled. So it causes high morbidity and mortality. It's data from the WHO source. It's not happening only happen in the country like Timor-Leste or lower middle income countries, but it also happened in the country that already has the advanced technology, something like that. So undiagnosed and uncontrolled CVDs, it's still remains our problem. Next. So from what should the country do? It's WHO already guide us. There is something very simple that we can do to tackle this issue. So prevention of the major risks, as we know, it's related to the behavioral, it's related to the metabolic and also environment. So we can intervene in that. So early detection, risk assessment, evidence-based treatment, primary health care integration, universal health coverage, and also population policies. And what more important is monitoring and accountability. So we can do this, we can address the main problem promptly about the cardiovascular disease. The principle is central principle that most move from the hospital center care to the primary care center prevention and management. So it's not, we are not talking about the tertiary health services, but we focus on the primary health services. Next. So this is the simple way that WHO show us how to deal with the CVD's issue, especially with the hypertension. So there is a way, strategy that we call HEARTS. So healthy lifestyle counseling, evidence-based treatment protocol, assess the essential medicine and technology, risk-based CVD management, team-based care, and system for monitoring. As individual, we can tackle the issue. We can deal with the CVD's problem, but it will better if we do this in the team. So nothing will, we will not miss many things when we do it in a team. And I remain again, for the monitoring is very important. It's included evaluation and a follow-up for the patient that's already treated by us. So HEARTS, it translates cardiovascular evidence into standardized primary care practice. Next. So the important things that we have to do is we detect, we treat, and we control. So I myself work in the healthcare facilities, in the primary healthcare facilities, deal with this NCD's problem. So every day I contact with the patient with the CBD's problem, and we apply the WHO approach for them, and little by little the result become good for us. So what we do is routine blood pressure measurement. We make sure that all the medicine that we use to treat is in place, and we build a follow-up system. Sometimes we call, sometimes we send a message through the mobile, and also through the community leaders to encourage a patient come to us. Even though we still struggle with our data monitoring, so it's become our big problem in Timor-Leste, and also standardize the treatment protocol, and we divide duties or task sharing between the health professional care and also the community leaders, and also we conduct the patient education both in facilities and also in the community, and ensure the health system accountability. So we open our health facilities and also the health system for the community to access directly, to give an input how we can deliver the good service, especially in the CVD's problem. So the challenge is implementation. It's not lack of knowledge. So the commitment, the attitude from the both sides, from the health professional care and also from the community or patient, is very important. Next. So why it's happened? Major disparities that can occur related to CBD's issue. So access is shaped more than distance to a clinical. So who are the vulnerable population? So people with a low income, people with the socially marginalized, people who live in rural and remote areas. As I told before, women, especially in country like Timor-Leste, and all older adults, people with the multiple morbidity, they are the one who are very vulnerable to the inequity services related to the CBD's problem. Next. In all these states, prevention, detection, treatment, continuity, and outcome, disparities can occur there. So we need to focus not only in the prevention or in the detection, but all the stages of the circumstance of CVD's problem: prevention, detection, treatment, continuity of treatment, and also the outcomes. We need to focus on all of that, because in every stage it can happen, the disparities. So what the message that we want to bring here is equity means reducing avoidable difference at every step, not only increasing the number of the service available. So as we say before, that the risk factor reduction, it's more important rather than the intervention of the curative. Next. So what the factor that influence this an inequity in cardiovascular disease? We can divide it and group it with 5 multi-level models. So it's related to the structural, it's related to the community, health system, interpersonal, and individual. See, the three of them is something that related to the human social anthropology. It's related to the human. It's related to us. The two other domain is related to the structure and the policy. So when we have commitment to deal with the CVD's problem, so we can start from ourselves as individual. We link to our patient. We build a good interpersonal relation with them, and we empower the community to tackle the issue with us as a team. So we bring them to our strategy, patient and also the community. With them, we can do something very good, very excellent related to the cardiovascular disease. Next. So the access, it's multidimensional. It's very clinical. We always focus on the health facilities. We also focus on whether the facilities can be accessed by patient, by people, or whether the service delivery is affordable for them. They can pay direct or indirect, or whether the service delivery is accepted for this community or not. It's against their culture, it's against their belief, or is service delivery is trustworthy or not. So, and also the main issue is the quality. This is the multi-level dimensional. We cannot handle this once in time, but we will do it stepwise, and then we encourage our community to more focus on what we can do based on our resources that we have. So a service can be technically available, but yet still be inequitable if people cannot reach, afford, trust, or benefit from it. Next. So common barriers, when this is the common barriers that happen in terms of the CBD's problem. It's a geographical problem, financial problem, service capacity, digital problem. Now we are in the digital era. There's a lot of things we can do with digitalization, information sharing, learning. We can do from that, but in some country, in some areas, remain problem for us. And other things are culture and linguistic problem barriers. So sometimes we have the health workforces, but in cultural and linguistic, they have problem with the community that they are work for. And also the barrier come from the care design. So how our health system run itself to deliver the service in terms of the CBD's problem. So like clinical hours, that when it's open and when closed, sometimes become the barrier for community to access. Next. So all of the factor, it just lead the patient to the very dangerous situation. So poverty, geography barriers, education barriers, gender, social exclusion just lead us to face the very big problem that caused by CBDs, stroke, heart attack, disability, premature death. So it's stepwise. It's slowly, step by step. When we are not focused, it will happen. So from social inequity to the cardiovascular death is something that will happen, certainly will happen if we are not focused on the reinforce to the reduction the barriers that we already know. Next. What the consequences of the limited access from misprevention to the late diagnosis and the avoidable complication. So the impact of the limited access can happen in the prevention process. So can happen in the diagnosis and acute care process, and also an impact in the long-term management. So in the prevention, when the inequitability happen related to cardiovascular disease, what happened is there is a risk factor detection and lower uptake of prevention. The risk accumulate silently, and it's become a very, very big problem for us. So in the impact on the diagnosis and acute care, so will happen delayed presentation and delay in diagnosis, and also high risk severity at the presentation. So because patient or people, it's come to us when they are already in the late stage. They already have heart attack. They already have stroke, something like that, and then it's become a very big problem for us to tackle. So the evidence show that rural patients with the AMI and heart failure have higher mortality rather than urban patients. It's shown in the 37th metaphysics study. Next. So in the long-term management, the for diagnosis, for it's not grow properly, promptly, because it interrupted or unaffordable, it will cause the decreased adherence, patient adherence to the treatment. So it will result the poor continuity treatment for the patient, and it become risk factor remain high, so it's become very hard for us to control. And of course, in the end, the outcome, it's not good for us, good for patient itself. So more complication will happen. The high number of admission to the hospital higher facility will happen because something happened in the early stage. So the key principle for us here is access is a clinical intervention, but improved access can improve diagnosis, treatment, initiation, adherence, and risk factor control. So when we address this correctly, so we can reduce the complication and admission to the higher facilities because of the serious problem. Next. Now I would like to bring you to my country, Timor-Leste, to know briefly about the cardiovascular disease in our country. So this is shift of the disease burden in Timor-Leste. Previously, we deal with the CDC's problem, infection disease problem, but now after maybe 10 to 15 years back, we start dealing with the NCD's problem. So it seems like both CDC and NCD's, they are competing to show which one it's increase rapidly rather than the others. So according to WHO, 45% of death in Timor-Leste attribute to NCD problem. And maybe it's globally quite the same. And around 73% of our population under year 35 years, they have a problem with hypertension. It's push us to start prevention in the early stage rather than to wait for them. And as a nation that with the high consumption of the tobacco, alcohol, and also unhealthy diets, we are emphasized to focus on the prevention for the risk factor, important risk factor. So rather than deal with the disease itself, because from our financial also has another issue that we need to consider. Next. So from the data shows that it's the hypertension more likely higher in women rather than in men. So from the rural studies, one island in Timor-Leste called Atauru Island. So the data shows that the prevalence of hypertension, it's about 25.8%, and also diabetes 1.26%. Smoking, alcohol is a prominent risk for the risk factor among men. Betel nuts use was particularly common among women and also men because it's very related to our cultural, our tradition here. Every moment that people gathering together, usually they provide tobacco, alcohol, and also betel nuts. So we use this in every single moment of our gathering together. So many hypertensive patients were previously undiagnosed or poorly controlled. It's happened in the Atauru Island. So, and another thing is in Atauru Island is because of the geographic condition. So the distance from the communities to the health facilities is quite long. So distance become the clinical risk factor for the Timor-Leste, especially in rural area, because our country is maintenance terrain and also the limited infrastructure related to the geographical issue, and many facilities that we put in the community is small, very small with the limited service. So just in Atauru, so people will reach the health facilities by walk around 2 hours. So sometimes they don't want to go to the health facilities and they access traditional medicine rather than from the hospital. So this means distance can cause delay screening. Delay screening can cause the delayed diagnosis, and it makes the delay treatment or proper treatment for the patient. So, but recently from 2024, 2025, with the WHO guidance, we apply package of the NCDs to tackle the NCDs issue in our country. So we call the program is PAN, NCDs disease package. So we focus on the early detection. So there is a lot of activities that we conducted in the community, early detection, risk factor management. We treat the hypertension very soon, and also diabetics, and also the other cardiovascular disease. So just WHO guidance with approach of hertz. Timor-Leste also apply the hertz approach in the our health system. So we bring the cardiovascular care closer to the community. Next. So the gap still remain. We have even we already apply the WHO PEN guidance, but unequal rural implementation still remain. Sustained coverage become our problem. So the community that live in the remote area remain our problem to access the services. And another thing is behavioral from our people and also from the health professional also something that we need to consider. And as a primary health care, there is a lack of the workforce, equipment, and also medicine. And the main problem, the another problem is also data. So we still struggle with this issue that we face every. So the policy is available, but it doesn't automatically reduce the equitable access. So there is four steps, four strategy, four solution that we address to tackle our situation. We strengthen the primary health care with various program. SISCA, it's the same like Posyandu in Indonesia. Peace, outreach, home visiting, we call it visita domiciliario. All the activities we conduct in among the communities. What we do there the pressure and also screen the blood sugar level in the community. Once we found out that there is a risk for them, we start the treatment and we refer them to the higher facilities so they can have the prompt treatment and also prompt diagnosis trial. So we make the primary care as the front door of the cardiovascular care. So as we say that bring the cardiovascular service closer to our community. So second solution we find and the missing patient, we try to communicate, we build the system, the communication between health professional and also the leader, local leader. Like Indonesian, it's RT, RW, maybe Tua Pemuda, something like that. So here also we have that kind of a structure. So we involve one there, and also PSF, the community person that live between his or her people that specifically appointed to deal with the health issue. We collaborate with them. As it's village, it's RT kampung has the PSF person. So this person is a bridge between community and health professional care. So we utilize them to deliver information, and also they encourage their community to come to seek the health professional health services, including CVDs. Solution 3. So we try to make a medicine and technology lab. Actually, this is the main problem for Timor-Leste because we have no pharmacy industry in country, all the medicine and all the technology, we depend to the another country, medicine especially from Indonesia and from India. So sometimes the procurement system, it's not worked very well. So sometimes we run out or stock out for our medicine, and also the malfunction of our equipment that we use to deliver the service. Next, the fourth solution is the our health workforces. We focus on them because of our lackness of the infrastructure, our unreadiness of the medicine equipment. So we really depend on our health workforces, our health professional, to close the gap to tackle the inequitability to access the health services, especially in the cardiovascular disease. So we encourage them to deliver the services at the individual level, at the family level, at the community level, and also at the health system level in the facilities. So at the system level, we encourage our health professional care to conduct the advocacy, encourage them to improve their quality of in terms of the knowledge, in terms of their competencies, and also in terms of their attitude. And also, we encourage our health worker to improve how to make documentation, especially to prepare good data for our policy to intervene our condition. So recommendation for Timor-Leste, there's a 5-point to tackle the equitability in the CBD's problem. It's a screen, treat, reach the patient or the vulnerable community, and then we track them, and when we advocate in terms to the access of the health services, and also the sustainability of the service delivery. So it's a two hands policy. One, we encourage health professional care, and the other hands, we also advocate the community and patient to access the services that provided by the country. So in our specific country priority, we focus on the primary care. So because it's stabilized in every village throughout the country. So as my terms of reference, that at least give something to my colleagues, students, nursing students. So how where nurse can intervene the situation related to the CBD's problem. As a strategy, the main thing that we need to consider is we move care closer to the people while protecting quality and continuity. So we bring all the services closely to the community. Dr. Sigit has mentioned it's empowerment of the community. It's more important because the reality is problem happen in the community more frequently rather than in health facilities. So it's also shift of the paradigm. We make the patient and community as our center of our service. Okay, so before we go to that, we know that why cardiovascular care fails globally. It's because of this. It's failed in the prevention, it's failed in the detection, it's failed in the treatment, it's failed in the sustainability, and it's failed because of inequality. But we need to optimize because we can, at least we can tackle the issue of cardiovascular disease with the prevention of the risk factor. So access barriers are particularly pronounced in low middle country income, but in it also happened in the high income country system. So we are in the same pages. For nursing, so the strategy is a practical community nursing strategy. What they can do is map the gap. So come to the community, come to the field, and do it with the team, not only oneself. So do this in the group, in team, systematically to identify and then conduct this screen closer to the community, closer to screening, closer to people. In cardiovascular disease, the main important thing is blood pressure screening and also blood sugar screening. Sometimes we have integrated equipment that can also test the cholesterol and also using acid uric in our blood. So this simple tools we can bring with us to the community, and then we stratify, we categorize them, and then prioritize who should get treated first, who we should intervene first, and then many things that cannot happen in the community. The intervention sometimes need higher facilities to intervene. That's why we strengthen the referral system. And then we follow up proactively the patient that the community that we already sent to the health facilities. And then once they go back to their community, we still conduct the proper follow up to them, so we cannot lose them. And then as the strategy, we also measure the equity, whether it's everything that we already done, it's meets the equitability or not. And because we are focused on the primary health care, so it's a community-based CVD package. What can a nurse do is a risk assessment, health promotion with the focus on the healthy lifestyle. And if we have patients in the community that they already treat, we give the support in the medication. Like here in the PSF, the person that we put there among the communities, sometimes they come to the patient and help this specific patient to get their medicine promptly. And also, as a nurse, we encourage the community to go to seek the further services that happen in the higher facilities. And nurse can, as an advocator, as a leader, can be a leader in the community. The main task is to engage community to the all process, so the community will feel that they are the one, they own this process, and every activities that do in their area is for them. So they are expected to actively involve in their activities. And now, because we live in the digital area, I think just like Her Excellency Governor in the Sulawesi and also in Jawa Barat, Her Excellency KDM used the digital approach to deliver service. I think nurse also, we can also health professional also can use the digital material to support our activities. So this should happen in the team task sharing and technology use safely. So we use the telephone. We avoid, because it's also risky, we avoid something that can harm our patient or ourselves. And as a quality safeguard, we use recommendation, especially the privacy protection. It's something that we need to focus on. The role of nurse in all these activities to tackle the cardiovascular issue uh, as a clinician. So it's a gatekeeper. So Dr. Sigit just mentioned that at least we prepare ourselves in our community. We are the one who at least attach the proper train about how to deal with the cardiovascular disease. So we have to be the first person once cardiovascular situation disease happen in our communities. So we we are the one who go first to help them. And as an educator, we translate, articulate all the knowledge to our community so they can prevent, they can change their lifestyle to prevent the CVD's problem. And we also, as the leader, we care, we act as a care coordinator. So give the community and patient many role, but we coordinate them so they feel that they are the one who should take their responsibility for their own health. So and we just lead them, we guide them toward the good approachment of health services. And we promote as a health promoter, and also we advocate, find out the solution. We come to the other partner, other government institution that established in the community. So together we can provide something very good for our patient, our community. And don't forget that there is another task that we need to monitor, because otherwise we lose everything just in the middle of our work. So as a health educator, we assess, we explain, we co-create with the community, we support, and then with them we evaluate whether all the activities that we done, whether the service that they receive, it's really benefit them or not, in terms of the quality and also the equitability. So this is a fact that can make us encourage us to do our job in our community based on the evidence. So the intervention from the nurse has really helped the cardiovascular disease circumstance being better. So 2025 and 26 data shows that there is impact of the nursing intervention on all the process. I think I come to the final presentation. So the key message is, of course, the cardiovascular disease. It's really global burden. So what should we do is identify, access, we reach especially the vulnerable communities and start to treat them and follow up. And last, we need to measure whether it's success or not. So we can make any change, we can adapt or we can adopt a new approach to the next intervention. So the conclusion from inequality to equity, the conclusion is it's not cardiovascular crisis. It's not simply about the disease, but it's about who is exposed, who get the screen, and who get diagnosed, who get treated, and who can afford to continue treatment, and who live close to the our facilities to receive care. So what we want to say to all of us here is we cannot achieve cardiovascular health equity by treating everyone the same. It's a very local based or local settings approach. So we achieve equity by removing barriers that prevent vulnerable people from receiving the care they need. I think that's all the presentation. Thank you. Atur nuhun. Obrigado, Bara.
All right, thank you so much, Mr. Joe, for your excellent and insightful presentation. So, due to the time, we will continue to the next agenda, which is the Q&A session for all of the participants who want to ask directly to the speaker. You can use the raise hand feature on the Zoom, or you can note down a question on the chat. Okay, Mr. Joe, we got our first question from Hayati, Poltekkes Kemenkes Banten is CVD is the leading cause of death and the greatest contributor to healthcare costs in Indonesia. One of the key strategies for preventing CVD is adopting a healthy lifestyle. However, based on my direct experience working with the community through health education, I have found that increasing public awareness of the importance of a health lifestyle remains challenging. For example, people sometimes do not fully recognize or fear the long-term consequences on uncontrolled hypertension when it's not properly managed through medication and health lifestyle changes.
Okay. Baik. Thank you. It's a very good question. But allow me to answer it in Indonesian. Deliver my opinion on that. May I speak in Indonesian?
Yes, Mr.
Oke, baiklah. Terima kasih ya, pertanyaannya sangat bagus. Itu masalah yang sangat umum yang kita hadapi setiap hari di mana saja. Ini terjadi juga di Timor Leste. Masyarakat dengan budaya tradisi yang begitu kuat, dengan pengetahuan leluhur yang begitu berakar, itu memang akan sedikit sulit untuk bisa memenangkan hati mereka. Tetapi pesan untuk teman-teman, untuk kita semua, tadi teman bilang itu pengalaman pribadi yang sulit. Saya juga mau katakan ini juga pengalaman pribadi yang mungkin akan membantu. Di mana pesan saya adalah karena meskipun kita menghadapi masyarakat, tetapi biasanya yang mereka akan lihat pertama itu bagaimana kita menguasai apa yang ingin kita sampaikan ke mereka. Jadi tolong persiapkan diri dengan baik sebagai seorang klinisian. dalam konteks ini sebagai perawat, persiapkan diri dengan baik, dengan ilmu yang memadai, agar ketika kita berhadapan dengan mereka, mau meyakinkan mereka, komunitas kita, segala macam kebimbangan dan keraguan yang ada itu bisa dihandle oleh penjelasan kita. Jadi memang sangat susah untuk memodifikasi tabiat atau perilaku seseorang, meskipun hal yang kita jelaskan itu mungkin baik. Jadi itu yang bisa saya sampaikan. Jadi pesan saya itu teman-teman mempersiapkan diri, keilmuannya itu diperdalam dengan baik. Jadi ketika hanya satu-satunya jalan untuk mengcounter itu dengan penjelasan yang ilmiah yang bisa mereka mengerti. Gunakan bahasa pendekatan dengan yang mereka di level mereka. Jadi jangan menggunakan istilah-istilah yang terlalu ilmiah, terlalu teknis sehingga mereka tidak bisa menangkap. Nah, itu yang disampaikan ke mereka, tetapi tetap menghormati otonomitas mereka, tetap menghormati budaya, culture, kepercayaan mereka, agama mereka, sehingga kita disambut dengan baik. Jadi tadi itu kan ada 3 domain yang berkaitan dengan manusia, komunitas, pribadi, personal, dan interpersonal. Jadi itu sangat penting. Bagaimana kita membangun komunikasi kita dengan orang lain, dengan pasien, dengan community, sehingga yang kita sampaikan itu bisa mereka terima dan bisa mereka ikuti. Saya kira demikian. Saya ini lagi di tempat pengerjaan fasilitas kami, jadi ada bunyi-bunyi aneh. Tolong dimengerti, maaf.
Baik, Mr. Joel, terima kasih atas jawabannya. Bagaimana Kak Nurhayati, apakah sudah cukup jawabannya? Okay, okay, thank you, Mr. And then we continue to the next question from Teddy Maulana from Poltekkes Kemenkes Banten. The question is, most cardiologists remain concentrated in major urban centers and deploying specialists to remote areas faces persistent facility and incentive constraints. Is it time for policy to formally authorize clinical task shifting for trained primary care nurse, such as protocol-based first-line antihypertensive titration and emergency ECG interpretation to cut preventable mortality from diagnostic delays in underserved communities? Okay, Mister, is the question clear? Hello, Mr. Joel.
Hello. Can you just repeat the question? It's very noisy here. So I'm so sorry.
Okay, Mister. The question is, the most cardiologists remain concentrated in major urban centers and deploying specialists to remote areas faces persistent facility and incentive constraints. Is it time for policy to formally authorize clinical task shifting for trained primary care nurses, such as protocol-based first-line antihypertensive titration and emergency ECG interpretation to cut preventable mortality from diagnostic delays in undeserved communities?
Yeah. So as I present in my presentation, just focus on the primary health care. So the message, I think it's clearly delivered there that it's very hard to deal with the CVDs, hypertension, when it's already come to the late stage or have the complication related to the hypertension. But okay. So as the protocol said, there is a certain or prompt treatment based on the evidence base, or we need to follow all the protocol that we write down. In Timor-Leste, we have the protocol that prepared with the WHO, that we follow that. But the problem is in the rural area, because of the demographic barrier, demographic issue. Sometimes, just I shared it before, that it's many times, it's not sometimes, many times we run out of our medicines. So many times we have the stock out in our medicine, and sometimes people, they come to us in a very late condition, so it's very hard for us to intervene in that moment. So what we encourage in Timor-Leste, and also for other country with the same status like us, is we intervene in the early process of this. Something that the WHO also emphasized, I think Indonesian and Timor-Leste, it's quite the same, is the intervene in the reducing the risk factor. So risk factor management is very important for us in country like this to win, to tackle, to overcome the cardiovascular disease. Of course, we cannot just forget the treatment with the medicine and also the health facilities in advance. But the main problem, the main point to intervene is is the risk factor management. So we know the risk factor for the CBD is related to it's very modifiable. So we can intervene there. So lifestyle changing, diet, the tobacco use, alcohol use, everything we can handle. We can do this. We can intervene this in there. So the main problem, how we can ensure, how we can convince our people, our community to change their lifestyle, to reduce the risk factor for the cardiovascular disease that they can occur to them. So I think that's the approach that in Timor-Leste we do, and I hope that yeah, it can apply in Indonesian too, because even Indonesian, it's not a lower middle country income, but Indonesian is one of the largest country in the world with the biggest, not biggest, but with the millions of people living in the country, and many of them, I think, live in the rural area too. So demographic issue, it's really something that we need to focus on, and we start, as we say, that we start with the risk factor management, something that we can intervene easier rather than medication or treatment itself. Thank you so much.
Thank you, Mr. for the answer. How about it, Mr. Teddy? Is that clear? Does that answer your question? Okay, while we wait for the response, we will continue to the next question. Maybe this will be the last question due to interest of time. And the question is from Fini Rahma Azahra from Universitas Falatehan. And the question is, if geographical barriers can delay presentation and diagnosis of cardiovascular disease, how can health system reduce this delay in a sustainable way, especially in rural and vulnerable population? while balancing investment in primary care, referral systems, transportation, and early detection. Okay, Mr. Joel, is the question clear?
Oh, hello. Sorry, I mute myself. I will try to answer this in Indonesia so I can share my idea to respond that. Jadi seperti yang sudah disampaikan sebelumnya, karena bahasa Inggrisnya juga jatuh bangun, saya harap teman-teman saya di sana bisa mengerti. Jadi yang saya katakan tadi memang sangat susah, sangat sulit untuk deal dengan masalah kardiovaskular ini. Jadi ketika itu sudah terjadi, itu akan menjadi beban yang sangat besar, bukan cuma buat pasien atau itu sendiri, tetapi bagi negara. Saya kasih contoh saja, karena Timor Leste itu menganut sistem pasien itu tidak mengeluarkan biaya untuk mendapat konsultasi kesehatan itu, pemeriksaan kesehatan, terapi segala macam, pengobatan semuanya gratis. Bahkan bukan cuma di dalam sini, ketika pasien dirujuk ke luar negeri juga semua dibiayai sama pemerintah. Dari semua penyakit yang ada, yang berkaitan kardiovaskular itu menduduki urutan paling pertama, setelah di bawahnya baru cancer. Kita tahu itu biaya untuk itu bahkan dalam 1 tahun itu sampai antara 6 sampai 18 juta dolar. Bagi negara sekecil Timor Leste itu mahal sekali harganya. Jadi itu benar-benar sesuatu yang harus kita khawatirkan, kita fokuskan. Lalu bagaimana biar kontinuitas keberlanjutan itu terus terjadi, terutama untuk mereka yang ada di rural area. Seperti tadi saya sudah katakan, dengan semua keterbatasan yang ada di Timor Leste, saya menjawab itu dari perspektif keadaan Timor Leste. Dari semua keterbatasan yang ada, keterbatasan infrastruktur, keterbatasan sistem referral yang ada, karena jarak, karena letak geografi yang begitu tidak bersahabat, tidak appropriate dengan kebijakan-kebijakan yang ada. Jadi intervensi yang bersifat lokal setempat itu sangat perlu, dan kita memberdayakan. Tadi yang dibilang PSF, Pesual, Saudi, Familia, itu seperti kalau di Indonesia mungkin petugas memberi obat yang bertugas untuk dulu kalau saya tidak salah itu yang mereka yang sakit TBC biasanya ada petugas kesehatan yang mendampingi mereka untuk kasih obat. Nah itu di Timor kita masih memakai sistem itu dan memberdayakan mereka untuk membantu supaya pasien yang tadinya sudah ada, sudah ditreat, sudah masuk dalam program PEN, ini jangan sampai hilang di tengah. Jadi karena ini kan penyakit-penyakit yang kronis, intervensinya bukan sehari, sekali, seminggu, sebulan, tetapi itu panjang masa pengobatan itu panjang, bahkan ada yang katakan sampai kita tahu mungkin seumur hidup. Nah itu perlu membangun sebuah sistem, sebuah pendekatan yang memastikan bahwa mereka ini mendapat obat tepat, obat yang benar di waktu yang tepat, dan mereka memastikan bahwa mereka benar-benar mengkonsumsinya. Jangan sudah dapat obat tetapi tidak. Nah, jadi itu yang bisa kita bangun dari negara-negara yang statusnya atau situasi geografinya seperti Timor Leste. Jadi memberdayakan local resource yang ada di sana. Jadi distribusi di Timor Leste ini kami juga menganut farmasi di bidang farmasi. Ya, jadi kita menggunakan sistem item box untuk distribusi obat dan medical supply dari pusat sampai ke rural, ke desa. Di sana itu semua terintegrasi dalam satu sistem yang kalau internetnya bagus, itu apa yang seorang dokter beri atau lakukan di satu desa terpencil itu bisa terekam jelas di dalam sistem yang ada di nasional. Jadi dalam hal ini, misal kita berbicara tentang ketersediaan obat, kelangkaan obat, jadi di sana itu bisa dimonitoring. Nah, hanya yang jadi masalah ini karena masalah geografis, itu banyak kali internet tidak bisa berjalan dengan baik meskipun listrik sudah sampai semua pelosok di Timor Leste sudah mengakses listrik, tetapi internet itu masih menjadi masalah. Jadi kadang ketika stok obat di sana sudah tidak ada, tetapi sistem tidak bisa menangkap sehingga supply ke sananya itu terlambat. Jadi terlambat. Lalu kadang-kadang kekurangan tenaga kesehatan terlatih, dokter, perawat di tempat tersebut tidak ada sehingga keberlanjutan itu menjadi terhambat. Ya. Jadi yang saya mau sampaikan kepada teman yang tadi sudah bertanya untuk memastikan keberlangsungan kontinuitas intervensi di lapangan di remote area seperti itu, ya memberdayakan sumber daya yang sudah ada dengan membangun sistem yang baik, komunikasi itu yang baik sehingga bisa dipastikan bahwa yang dilakukan di kering di lapangan di remote area tersebut benar-benar sesuai dengan protokol yang kita ada dan bisa memastikan keberlanjutannya itu dengan baik. Demikian, terima kasih.
Okay, thank you to Mr. Dr. Joao Manuel Correa Simanes for the very useful and insightful answers, which have provided us with new knowledge. Perhaps we will end the questions and answer session here. I'd like to express my deepest gratitude to Mr. Dr. Joao for taking the time to attend and deliver his extraordinary presentation. I hope that the material presented today will be useful for all of us. Ladies and gentlemen, before ending this session, please allow me to briefly summarize our discussion. Cardiovascular disease remains the leading cause of death worldwide, and the burden is highest in low and middle-income countries due to unequal access to care. And it's caused by multifactorial and involves many systems. And hypertension becomes the root of many CVD problems, so it's important to overcome the hypertension before it becomes complicated into CVD. And also earlier, Mr. Joao also outlined several solutions that could be implemented, such as the 5-point recommendation: screen, treat, reach, track, and advocate. And also, that's all need the collaboration and cooperation for multisectoral. And cardiovascular health equity will only be achieved when we remove the barriers of distance, cost, and poor detection, and bring prevention and treatment closer to the communities who need it most. And also, Mr. Joao say that we as a nurse can do the simple things like an assessment, help promotion, and give support for the community to take a medicine and encourage them to seek further treatment if they are diagnosed to CVD disease. Okay, maybe that's all from me. Once again, thank you so much for all of the participants for the attention, and thank you so much for Mr. Joao for the excellent presentation. As the moderator, I would like to take my leave. My apologize for any mistakes and shortcomings. That's all. Thank you so
Terima
much.
kasih. Thank you so much. See you again.
See you again, Mr.
Thank you to Dr. Joa Manuel Soria Jimenez for your excellent presentation, and to Mrs. Afifa Nurmali Hidayah, IMDK, for guiding the session with professionalism.
Terima kasih kepada Dr. João Manuel Soria Jimenez yang telah menyampaikan materinya dengan baik, serta kepada Ibu Afifa Nurmali Hidayah, AMDK, yang telah memandu jalannya sesi dengan penuh profesionalisme. Please give applause to our speaker and moderator.
Thank you.
For the next is the presentation of the fourth material, What's Work in the Real World, Community-Based Cardiovascular Intervention that Actually Make Impact by Mrs. Luciana Sampe, MCOP Nurse SP Kepkop, and moderated by Mrs. Yunita Sari, MCOP SP Kepkop. We now respectfully, the stage is yours.
Selanjutnya, penyampaian materi keempat, apa yang efektif di lapangan, intervensi kardiovaskular berbasis komunitas yang berdampak nyata oleh Ibu Luciana Sampe, MKepnes SP Kepkom, dan dimoderatori oleh Ibu Yunita Sari, MKep SP Kepkom. Dengan hormat, kami persilakan.
Okay, thank you for the Master of Ceremony. We meet again, yeah. I think this is the last speaker today. We have Mrs. Luciana. Oke, Salama Karampuanta Inde Poltekkes Banten, Mrs. Lucy. Karena Bu Lucy ini dari Tanah Toraja, jadi kita sambut dengan bahasa Toraja. Oke, before we start, I would like to read the curriculum vitae for the the last speaker. Sorry, Mrs. Luciana Sampe, Master of Nursing and Community Health Nursing Specialist. Okay, okay. We see from the. So sorry, committee. This is the CV of the Mrs. Dr. Nur. Yeah. Bagaimana kabarnya Kak Lucy?
Kabar
Sehat?
baik Mbak Nita, sehat.
Eh,
Suara saya bisa kedengaran ya?
yes, yes. I can clearly hear your voices.
Oke, thank you.
Okay. Do you have any problem or I must share the CV by myself? Okay, I have the CV. Maybe I would like to share by myself. Yeah. Hmm. Okay. Okay. Can you see the CV of our speakers today? Bisa terlihat ya? Sudah bisa terlihat? Okay, I would like to read the CV of Mrs. Luciana Sampe, Master of Nursing and Community Health Nursing Specialist. She is originally come from Sulawesi Selatan, south of Sulawesi, and she was born on May 19 76 in Tikuna, Malenong. Yeah. From the educational background, Mrs. Luciana completed her master's degree in nursing and her specialist program in community health nursing from Universitas Indonesia. Yeah, and from the riwayat pekerjaan, she brings a wealth of hands-on and administrative experience in public health, and she has served in primary healthcare centers, clinical settings, and key administrative roles within the Tanah Toraja District Health Office. Currently, she serves as a health administrator at the Tanah Toraja District Health Office and a lecturer in the master program of community health nursing at Universitas Hasanuddin. And she also an accredited primary healthcare surveyor with the KAKP or KEKL accreditation board. Okay, and her extensive expertise is in community nursing and health services administration and primary healthcare accreditation makes her uniquely qualified to address today's topic. Mrs. Luciana, we have about 45 seconds, and we are truly honored to have you with us today. And please feel free to share your screen and begin. Thank you.
Okay, thank you very much, Mrs. Yunita. You can hear me, okay?
Yes, it's clearly. You can share your PPT. Okay.
Yes. First of all, I would like to sincerely thank you for Poltekkes Kemenkes Banten for giving me the valuable opportunity to share and be part of this international seminar. It is truly an honor for me to be here today. Thank you. The topic is what works in the real world community-based cardiovascular intervention that actually make impact. Ya, jadi kalau sepanjang hari ini sejak pagi tadi kita sudah berdiskusi, kita sudah mendapatkan materi tentang kardiovaskuler mulai dari pencegahannya, penanganannya tadi oleh Pak Sigit, ya kemudian yang baru-baru ini dari Dili, bagaimana penanganan kardiovaskuler untuk kelompok rentan. Hari ini, saat ini saya diberi kepercayaan dan ini adalah kepercayaan yang luar biasa, tantangan juga bagi saya untuk membagikan pengalaman mungkin karena sehari-hari saya bertugas sekarang ini di Dinas Kesehatan, ya, di Dinas Kesehatan meskipun part-time untuk menjadi pengajar juga di Universitas Hasanuddin seperti yang ada di bibliografi tadi ya. Nah, next. Okay. Strategic objective from global burden to local execution. Ini the evidence, understand the core principle and proven effectiveness of community-based cardiovascular intervention. Jadi selama ini ada bukti yang prinsip bahwa komunitas itu intervensi komunitas sudah banyak buktinya ya, sudah banyak kita lihat bahwa bukti-bukti intervensi berbasis komunitas, sudah banyak penelitian yang menampakkan atau membuktikan hasil bahwa intervensi di komunitas itu arahnya sekarang ini sudah dilakukan di komunitas. Kalau selama ini di Kemenkes, memang promotif preventif itu digaungkan, tetapi seperti hanya digaungkan saja, ya. Masih 50-50 antara prevention dengan kuratif yang selama ini, tetapi 10 tahun terakhir program untuk promotif preventif itu sudah lebih digalakkan. Nah, yang terbaru 2 tahun terakhir ini, the policy master of upcoming 20 and 26 free health check, ya. Kalau di kita dikenal dengan cek kesehatan gratis. Free health check guidelines and primary care EKG clinic triage pathway. Khusus untuk kardiovaskuler, untuk di CKG ini atau free health check ini bisa diketahui dari pemeriksaan EKG sebenarnya. Cuma yang bermasalah sekarang di EKG itu banyak puskesmas yang belum memanfaatkan alat EKG ini karena berbagai faktor. Mulai dari faktor manusianya, ya, perawat-perawat kita yang masih kurang terlatih dan karena kurang menggunakan, kurang memanfaatkan alat EKG selama ini, sehingga ilmu yang didapatkan pada saat pendidikan itu seperti terpendam, ya. Jadi sudah lupa bagaimana cara mengecek pemeriksaan jantung melalui elektrokardiografi. Nah, CKG ini, free health check ini sudah dimulai tahun lalu, tahun 2025, launching pada 10 Februari, dan sampai sekarang ini saya tidak tahu ya apakah kita peserta seminar hari ini termasuk staf dan tim tenaga pendidik di Poltekkes Kemenkes itu sudah pernah terpapar atau sudah pernah memanfaatkan cek kesehatan gratis ini, ya. Karena sepanjang hari kita sudah berbicara panjang lebar bahaya dari cardiovascular disease. Rupanya kardiovaskuler ini tidak menghitung jam, tidak menghitung waktu yang terlalu lama. Kalau penanganannya kurang tepat, bahkan tidak ditangani, hanya dilihat-lihat saja, maka kematian itu bisa terjadi dan itu tidak bisa tertolong, ya. Tadi digambarkan oleh Pak Sigit bagaimana kalau misalnya kita sementara di kereta atau di kampus seperti sekarang ini lagi ada acara atau lagi ada perkuliahan normal, kemudian tiba-tiba ada yang pingsan, apakah ada di antara kita atau ada kemampuan untuk menangani kasus-kasus emergensi seperti itu? Nah, oleh sebab itu, sebelum itu terjadi, pemerintah melalui Kementerian Kesehatan sekarang ini meluncurkan cek kesehatan gratis yang itu betul-betul gratis, ya, bukan hanya slogan bahwa cek kesehatan gratis, memang benar-benar gratis, tidak dibayar 1 sen pun. Cuma kendalanya kadang karena ini adalah program untuk semua siklus hidup, mulai dari bayi baru lahir sampai lansia, diperiksa sesuai dengan umur, sesuai dengan kategori kelompok usia, ada karakter-karakter, ada screening yang dilakukan sesuai dengan siklus hidup itu, sehingga masih banyak kendala yang kami hadapi di lapangan. Ini adalah tahun kedua. Ya. Next. Next slide, please. Ya. Ini adalah 10 besar beban kesakitan dan kematian dari hasil cek kesehatan gratis itu, dan ini secara global pun demikian ya. Ini dari siklus hidup mulai balita, anak, remaja, kita lihat pada usia dewasa 20 sampai 39 tahun itu didominasi oleh penyakit kardiovaskuler, demikian juga sampai lansia. Jadi penyakit kardiovaskuler ini mulai terdeteksi rupanya mulai umur 20 tahun. Nah, peserta seminar hari ini pasti sudah berada di atas usia ini ya. Seperti tadi saya katakan, apakah kita yang hadir pada siang hari ini sudah pernah mengecek kesehatan kita sendiri, terutama tentang kesehatan jantung kardiovaskuler, karena secara statistik data dari Global Burden ini 2023 mulai usia 20 sampai lansia, penyakit 10 besar yang mendominasi itu adalah penyakit kardiovaskuler. Ya, next. Beban kematian penyakit-penyakit tadi ini yang kardiovaskuler mulai dari umur 20 tahun, kita lihat hasil survei tahun 2009 dan 2023. Kalau di 2009 itu didominasi oleh stroke. Stroke ini masih top skor ya, 10 penyakit untuk 2023. Jadi dalam jangka 4 tahun belum bergeser dari stroke tetap stroke. Kemudian yang dahulunya ischemic heart disease, ya, penyakit jantung iskemik, itu di urutan keempat tahun 2009, naik ke urutan kedua pada tahun 2023. Kemudian yang signifikan lagi adalah diabetes, DM ya. Dari 2009, tahun 2009 itu berada pada urutan ke-9, naik menjadi urutan keempat pada tahun 2023. Dan 4 penyakit beban pembiayaan terbesar, tadi juga Pak Sigit menyampaikan beliau bekerja ya, menjadi salah satu tim kendali mutu, kendali biaya di BPJS, mendapatkan bahwa pembiayaan yang paling besar untuk penyakit-penyakit ini, 4 terbesarnya itu ada di penyakit jantung. Kemudian penyakit gagal ginjal, kanker, dan apa nih yang keempat nggak kelihatan. Ya, jadi keempat penyakit ini sebenarnya karena dia pembiayaan yang begitu besar, setelah ditelusuri dari awal mulainya penyakit ini, sebenarnya 4 jenis penyakit ini, terutama jantung, itu mampu dicegah jika diketahui sedini mungkin. Jadi sebelum umur 20 tahun, kalau bisa sudah dilakukan pemeriksaan jantung, dan yang wajib sekarang ini di CKG itu adalah umur 40 tahun wajib EKG, ya, wajib EKG dan wajib pemeriksaan lemak darah, fosfolipid. Ya, next slide. Nah, dari hasil CKG yang terbaru, karena ini tadi saya sudah katakan bahwa penanganan penyakit jantung itu susah, ya, harus cepat, harus tepat, sehingga angka kematian sangat tinggi. Nah, bagaimana supaya itu tidak terjadi? Ya, kita harus punya data apa sebenarnya yang ditemukan secara nasional di Indonesia. Dari hasil CKG yang terbaru tahun ini, dari 1 Januari sampai dengan Agustus, ini sudah dirilis ada 27 provinsi yang sudah melakukan pemeriksaan tekanan darah dan didapatkan capaian pemeriksaan yang diperiksa tekanan darah itu sudah cukup besar. Jadi secara garis besar kita lihat yang warna hijau capaian pemeriksaan ya. Sudah banyak yang diperiksa. Lebih dari 90% masyarakat sudah diukur tekanan darahnya. Dan dari 90% ini yang diperiksa tekanan darah itu banyak yang ditemukan ternyata hipertensi dan hipertensi ini awalnya tidak disadari. Jadi hipertensi awalnya biasanya mungkin orang hanya bilang pusing-pusing, sakit kepala, tidak enak badan ya. Tapi karena tidak memeriksakan diri karena di kita orang Indonesia sekarang ini menganggap sakit kalau sudah tidak bisa bergerak, sudah tidak bisa melakukan aktivitas sehari-hari, baru menganggap dirinya sakit. Padahal kalau itu diperiksakan sejak dini, dicek sebelumnya, ketahuanlah hal-hal yang seperti ini, temuan hipertensi, kemudian dari yang ditemukan hipertensi itu ternyata yang ditindaklanjuti ya atau diberikan pengobatan, diberikan tata laksana belum semua. Tadi Pak Sigit menyampaikan kalau data di BPJS 20% lebih ya atau 40% lebih yang ditemukan bermasalah, ternyata yang ditata laksana atau yang diobati itu hanya 2%. Jadi memang masih besar gap antara yang ditemukan, kemudian yang diperiksa, kemudian ditemukan masalah, dan yang ditemukan masalah ini ditindaklanjuti atau diberikan tata laksana. Jadi di situ masih banyak permasalahan di sekitar itu. Ya, next slide. Ya, next slide. Next, ini sudah. Oke. Nah, di implementation gap, we excel at detection but fail at management. Ini tadi ya yang saya sudah katakan bahwa untuk blood pressure screening blood pressure di CKG itu di DKI Jakarta sudah mendeteksi high detection capacity in Jakarta 95% yang sudah di screening, yang sudah diperiksa untuk blood pressure. Kemudian untuk blood glucose, screeningnya blood glucose ini 92%, tetapi yang di successful untuk manajemen hipertensi itu belum cukup 30%. Kemudian untuk diabetes di manajemen sekitar 35%. Jadi masih banyak sekali yang sudah ditemukan tetapi belum diobati. Ini yang sudah ditemukan, bagaimana yang belum ditemukan. Jadi itu masalah yang masih sangat besar di masyarakat kita, terutama di Indonesia. Next slide. The evidence dashboard intervention that move the needle. Jadi ada beberapa hasil penelitian yang saya coba dapatkan terkait dengan cardiovascular diseases ini. Yang pertama dari tentang community death counseling. Ini menemukan systolic blood pressure itu menurun 8,4 mm hidrogirum diastolnya. Jadi diastol bisa menurun dari counseling diet, ya, hasil penelitian Butia et al. 2024 ini counseling diet itu mampu menurunkan systolic blood pressure and diastolic blood pressure. Kemudian physical modalities ini mampu juga melalui combined training significantly lowers 10 years Birmingham risk score. Jadi melalui physical activity ini juga mampu menurunkan systolic blood pressure meskipun dia lebih rendah, hanya 7,01 mm. Dan ada lagi penelitian dari multi-komponen hybrid, multi-komponen hybrid ini oleh Chus et al. Menemukan bahwa ada signifikan meningkatkan perilaku, significantly improves heart and healthy behavior, self-efficacy, fasting blood glucose better than standalone apps. Jadi penelitian ini meningkatkan self-efficacy dan perilaku sehat dari penelitiannya. Yeah. Next slide. The 2026 CKG policy shift, khususnya ini di Indonesia. Saya sudah katakan tadi bahwa di Indonesia kita ada program PHTC, program hasil terbaik cepat Presiden Prabowo, termasuk CKG ini existing paradigm threshold based screening, check all adults for blood pressure more than 140/19. Jadi mengecek tekanan darah jika lebih dari 140/90 mm hidroglycerin, ini harus dilakukan cek kesehatan pengukuran tekanan darah secara berkala. Jadi bukan hanya sekali, tetapi kalau bisa minimal 1 bulan sekali harus pengelola program di puskesmas itu memantau tekanan darah pada pasien-pasien atau pada individu yang didapatkan terdeteksi hipertensi. Ya. Pada saat screening kemudian terdeteksi hipertensi ini oleh pemegang program. Jadi sistemnya seperti ini teman-teman. Cek kesehatan gratis itu dilakukan pada seluruh individu sesuai dengan siklus hidup. Kemudian hasil dari cek kesehatan gratis ini, hasil pemeriksaan individu-individu ini dilanjutkan atau ditindaklanjuti oleh pemegang program, pengelola program yang ada di puskesmas. Karena di puskesmas itu banyak pengelola program, ada pengelola program penyakit menular, penyakit tidak menular, jadi akan ditindaklanjuti oleh mereka. Kemudian untuk yang cek for glucose anomalies dan HbA1c, kemudian glukosa fasting jika lebih dari 126, maka itu juga sudah menjadi tanda ya, sudah warning untuk terjadinya gangguan kardiovaskuler. History based targeting, specifically target patient age more than 40 years. Jadi spesial untuk pasien yang lebih dari 40 tahun itu wajib hukumnya harus diperiksa tekanan darah dan periksa gula darah dan periksa fosfolipid atau lemak darah. Karena bagi pasien yang terdeteksi hipertensi dan menderita diabetes mellitus, risiko untuk menderita kardiovaskuler itu lebih besar, ya, lebih besar dibanding dengan yang tidak hipertensi dan tidak DM. Requires a prior history of hypertension or diabetes mellitus. Jadi inilah pentingnya pemeriksaan hipertensi yang bagi orang awam itu alah gampanglah cuma pengukuran tekanan darah kok, ya, atau pengukuran kadar gula darah. Kata orang hanya dengan olahraga itu bisa normal, ya. Tetapi sekali hipertensi itu akan mengkonsumsi obat seumur hidup, sehingga perlu pencegahan jangan sampai kita terdiagnosa hipertensi, karena sekali hipertensi wajib hukumnya secara teori itu harus mengkonsumsi obat seumur hidup, ya. Oleh sebab itu tahun 2026 ini dimandatori, diinstruksikan, ya, the 20 and 26 mandate introduce mandatory advanced diagnostic at primary care FKTP kalau di puskesmas for this cohort, testing lipid profiles and EKG elektrokardiogram. Jadi sekarang untuk di 2026 ini CKG atau pemeriksaan kesehatan gratis itu bukan hanya sekedar untuk men-screening atau memeriksa sebanyak-banyaknya orang, tetapi lebih ditekankan pada bagaimana melakukan pemeriksaan dan menemukan sebanyak mungkin, terutama individu-individu yang berisiko menderita kardiovaskuler, seperti usia yang ini usia lebih dari 40 tahun. Jadi wajib EKG dan periksa profil lipid atau lemak darah. Sekali lagi, biasanya kita orang kesehatan pintar ngomong, pintar memberikan penyuluhan, tetapi bagaimana dengan diri kita sendiri. Oleh sebab itu biasanya di Hari Kesehatan Nasional itu metodenya adalah sehat dimulai dari saya, ya. Kita menilai diri kita kembali saja, apakah kita sudah melakukan pemeriksaan yang mungkin ini sangat simpel, ya. Pemeriksaan tekanan darah, pernahkah kita mengukur tekanan darah kita apakah masih aman-aman saja atau sudah pernah lebih dari 140 mm per 90, atau gula darah kita apakah sudah pernah lebih dari 120 pada saat pemeriksaan glukosa darah sewaktu, ya. Mudah-mudahan dengan seminar kita pada siang hari ini bisa memberikan kita bukan hanya pengetahuan, bukan hanya kita sekedar tahu bahwa kesehatan itu penting, ya, pencegahan itu penting, tapi betul-betul kita sadar, kita memahami ada faktor risiko termasuk umur, di mana umur itu tidak ada satu orang pun yang bisa menghentikan dan tidak ada satu orang pun yang bisa terhindar dari yang namanya usia bertambah. Ya. Kalau saya sekarang sudah lebih dari 40, saya sudah 50 lebih, ya. Jadi sudah berisiko ini, tetapi syukur saya beberapa kali periksa masih aman sampai sekarang. Oke, next. Ya, this is diagnostic matrix simplifying EKG triase at primary care. Jadi ini adalah prosedur atau protap pemeriksaan setelah pemeriksaan EKG yang dilakukan teman-teman di lapangan, apakah itu mereka melakukan pada saat screening CKG kemudian mendapatkan pasien yang berisiko untuk mengalami masalah kardiovaskuler. Nah, individu yang seperti ini dilanjutkan ke puskesmas untuk ditindaklanjuti, diberikan tata laksana oleh pemegang program di puskesmas. Jadi ini mungkin secara teori ya, teori kalau kita belajar di kardiovaskuler, mungkin ini di next saja. Ini lebih berbicara tentang protap. Ya, ini masih lanjutannya. Yang penting adalah the clinical triage pathway translating data to action. Jadi, if the patient more than 40 years with hypertension or diabetes mellitus history and EKG perform, jadi tampilan EKG-nya apakah itu normal atau sinus rhythm, perlu diberikan hanya edukasi bagaimana diet, bagaimana activity, bagaimana untuk berhenti merokok ya. Kalau misalnya hasil EKG-nya kita mendapatkan hasilnya masih dalam sinus rhythm masih normal ya. Kemudian untuk selanjutnya standar hipertensi DM ya, ini lipid ya, pemeriksaan lemak darah tadi, dan itu diulangi 1 kali dalam setahun minimal. Kemudian untuk yang mengalami kronik abnormal atau dari hasil EKG-nya terdeteksi ada masalah kronik, maka ini harus di manage at FKTP capacity. Jadi ditindaklanjuti untuk pengobatan di puskesmas dan kalau perlu ini standar referral to FKRTL. Jadi fasilitas kesehatan tindak lanjut ini sudah di rumah sakit. Jadi kalau sudah ada masalah tidak bisa disimpan atau dirawat inap atau apalagi kalau misalnya pasiennya minta pulang itu tidak boleh ya. Jadi ini secara protap harus dirujuk ke FKTL. Kemudian untuk yang akut abnormal seperti yang tadi sudah dibicarakan panjang lebar ya, ini bagaimana kita harus lebih fasih, lebih paham untuk penanganan masalah kardiovaskuler. Tetapi ini harus orang yang terlatih ya, bagaimana menstabilize ABC, airway, breathing and circulation, kemudian pemberian administer antiplatelet ya, kemudian statin apakah itu atorvastatin atau simvastatin untuk penurunan kadar lemak darah. Dan immediate ini refer to FKTL, fasilitas kesehatan tindak lanjut. Jadi memang kardiovaskuler kalau sudah bermasalah tidak bisa lagi dibiarkan di komunitas, dibiarkan di puskesmas, dia harus ditindaklanjuti di rumah sakit. Next.
Okay, Mrs. Lucy, you have 8 minutes more.
Okay, thank you for your
Reminder.
Yeah, the reminder. The strategic nodule. Ini peran perawat ya. Bagaimana peran the community nurse. Pentingnya untuk pencegahan itu betul-betul kapasitas seorang perawat yang ada di komunitas. Kenapa dia sangat penting? Karena the community nurse ini berada di antara individu, ya, antara individu apakah itu pasien, kemudian berada di antara keluarga, community dan sistem kesehatan yang ada. Jadi bagaimana penampilan atau peran seorang perawat menjembatani antara individu, keluarga, komunitas dan sistem pelayanan kesehatan yang ada. Next. Okay, next, please. Yeah. Operationalizing impact ini POACH framework, planning, organizing, updating, controlling. This is the peran perawat tadi itu bagaimana merencanakan ya, access plan, moving the individual symptom, checking to population data collection, hypertension, diabetes mellitus, obesity prevalence, and identifying high risk communities cluster. Then organizing, collaborate, building structure partnership with puskesmas, local government, and mobilizing community health workers. Kader kesehatan ya, kita sebutnya kader kesehatan. And then actuating implementation, shifting from purely facility-based treatment to community-level primary prevention, proactive screening, active lifestyling, promotion and continuous counseling, and then controlling, monitor and evaluate, setting measurable targets, tracking blood pressure and glucose control rate over time to ensure intervention remain effective and sustainable. Next. Next slide. Yes. Accelerator and friction points in the real world. Accelerators, active community engagement, train community health workers, strong local government support, multidisciplinary collaboration, and the digital equalizer. Jadi tadi juga sudah disampaikan bahwa sistem digital sekarang ini sangat membantu di dalam penerapan promotif preventif untuk kesehatan individu. Jadi melalui cek kesehatan gratis itu ada screening mandiri yang bisa diisi oleh peserta. Jadi misalnya kita yang akan mengikuti cek kesehatan gratis itu ada website, ada link, ada juga aplikasi diinstal, kemudian kita mengisi screening kesehatan mandiri. Setelah kita mengisi screening kesehatan mandiri ini, kemudian ke FKTP untuk melakukan pemeriksaan, dan hasil dari hasil pemeriksaan di FKTP atau di puskesmas, di fasilitas kesehatan itu dikirim melalui nomor WhatsApp kita dalam bentuk rapor kesehatan. Jadi kalau rutin melakukan cek kesehatan, itu akan ada rapor kesehatan, jadi kita bisa melihat perkembangan status kesehatan kita dari tahun ke tahun. Kalau misalnya dilakukan hanya 1 tahun sekali ya hasilnya 1 tahun sekali, tapi kalau bisa lebih ya bisa lebih dari itu. Ya. Next slide. Ya. This is the blueprint for impact and continuous loop of care. Jadi the first is screening ya. Proactive risk detection, ini this is the CKG health kesehatan tadi, CKG 2026, kemudian educate enhance community health literacy, jadi melalui pendidikan kesehatan, apakah itu kepada kader, kepada keluarga pasien, bukan hanya bagaimana mereka mengetahui kesehatan atau mengetahui tentang penyakit kardiovaskuler, tetapi tujuan dari edukasi ini adalah bagaimana apa yang kita berikan itu bisa memberikan pengetahuan, kemudian kader menyadari dan bisa mengenali faktor risiko, mereka berisiko atau tidak, kemudian bisa terjadi keyakinan diri, ya, dia meyakini bahwa oh saya sehat atau saya sudah berisiko, kemudian bisa mengambil keputusan. Jadi tujuan dari educate itu adalah meningkatkan pemahaman masyarakat, dan terutama adalah bagaimana mengambil keputusan yang tepat untuk perbaikan atau pencegahan dari faktor risiko kalau dia sudah tahu, dia sudah diberikan pemahaman bahwa penyakit kardiovaskuler seperti ini ya. Kemudian yang ketiga empower. Empower ini memberdayakan ya, building patient self-management skills, and then engage mobilizing families and community health workers, and then monitor continuously tracking blood pressure, glucose, and lifestyle, and then number 6, refer seamless triage to primary and specialist facilities, and the last number 7, follow up sustaining care via home visit and digital tools. Ya, jadi bagaimana keberlanjutan dari hasil screening di awalnya, kemudian kita memberikan edukasi, kita menggerakkan masyarakat, dan yang paling penting adalah bagaimana keberlanjutan dari program ini dilakukan ke depan. Jadi bukan hanya satu kali, habis itu selesai, tidak ada tindak lanjut. Tapi untuk pasien-pasien yang terdeteksi ada masalah kardiovaskuler itu harus ada sustain, ya, perawatan sustain melalui home visit and digital tools. Apakah kita berkunjung ke rumahnya atau kita bisa meminta nomor-nomor WA, ya bisa menghubungi obatnya sudah diminum atau belum, bagaimana dengan tekanan darahnya, apakah rutin berobat, obatnya masih ada atau tidak. Kalau dia sudah kena terdeteksi diabetes, maka apakah obatnya masih ada, ya jangan sampai tidak diminum, kemudian aktivitas fisiknya bagaimana, dan aktivitas fisik itu kembali tetap disesuaikan dengan kemampuan dan masalah yang dihadapi. Jadi jangan semua pasien harus aktivitas, karena sekarang kan banyak sekali ya orang olahraga, lari, apa segala macam. Tetap kita harus mengingatkan bahwa aktivitas fisik itu sesuai dengan kemampuan dan sesuai dengan kondisi yang masih bisa ditolerir oleh individu yang melakukannya. Jadi jangan seperti kita yang tidak pernah olahraga, kemudian tiba-tiba mau lari atau mau jalan, mau olahraga sampai gobios, sampai panas-panasan, sampai apa ya. Yang dianjurkan adalah bagaimana educate untuk aktivitas fisik itu rutin, ya rutin 3 kali seminggu, 1 kali melaksanakannya 30 menit, ya seperti itu. Jadi bukan olahraga yang keras, karena kita ini bukan olahragawan, tetapi hanya untuk maintenance, ya, untuk aktivitas fisik itu supaya tetap berjalan, bisa mengontrol tekanan darah dan bisa menyegarkan tubuh, ya. Next, maybe this is the end slide. Next, seperti ini sudah yang terakhir. Oh ya, thank you for my presentation. Mohon maaf jika ya English-nya terbata-bata, karena ya seperti itulah kita yang di lahan ini sudah tidak terlalu mengejar TOEFL dan segala macamnya ya. Jadi sekali lagi mudah-mudahan bisa ada yang diterima, ada yang dimanfaatkan dari apa yang saya sampaikan. Thank you, and saya kembalikan ke moderator.
Okay, thank you very much, Kak Lucy, Mrs. Lucy, for such an insightful presentation. Jadi teman-teman ini Bu Lucy ini lebih banyak bermain di lapangan begitu ya. Beliau lama di dinas kesehatan, sehingga apabila ada dari teman-teman yang ingin bertanya, now we have about 10 up to 15 minutes for question and answer session. If you have any question, you can raise your hand, maybe. Is there any question here? Oh, okay. We have question from Vini. Oke, thank you Vini. Selamat siang, Miss. Saya ingin bertanya, apabila kemampuan deteksi itu sudah tinggi, tetapi pengobatan dan tata laksana masih rendah, apakah masalah ini masih dianggap utama sebagai masalah akses pelayanan, atau justru menunjukkan adanya kegagalan dalam desain kesinambungan pelayanan, dan bagaimana kita bisa membedakan keduanya? Okay, maybe Mrs. Lucy want to answer directly right now.
Okay,
Silahkan.
yeah, thank you, Miss Vini. Ya, ini dari luar ternyata ya, tapi orang Indonesia ya. Boleh saya jawab dengan bahasa Indonesia saja ya, karena saya tidak mampu berbahasa Inggris seperti yang lain ya. Jika kemampuan deteksi sudah tinggi dan pengobatan tata laksana masih rendah, apakah masalah ini dapat dianggap terutama masalah akses pelayanan? Eh, ya, berbicara tentang akses, ini akses itu bukan hanya bukan hanya bagaimana kita menjangkau pelayanan kesehatan. Selama ini kita pahami akses itu hanya dari misalnya dari tempat kita bagaimana bisa ke puskesmas atau dari tempat kita bisa ke rumah sakit. Selama ini yang lebih banyak dipahami seperti itu, akses dalam hal jarak. Nah, tetapi yang sebenarnya berbicara tentang akses bukan hanya tentang jarak untuk menjangkau fasilitas pelayanan kesehatan, tetapi bagaimana mengakses atau mendapatkan pelayanan itu sendiri ya, selain dari akses jarak, tetapi yang selanjutnya adalah bagaimana akses terhadap pelayanan itu. Memang sekarang ini dari cek kesehatan gratis itu karena memang ditargetkan dari Presiden Prabowo ini harus mencapai 46% tahun ini ya, targetnya itu kan setiap tahun naik. Kalau tahun lalu 36% dari jumlah penduduk, tahun ini naik 46% dan itu akan berakhir sampai di 2029 nanti sesuai dengan 5 tahun kepemimpinan beliau. Terakhir itu harus dicapai 90%. Nah, tahun ini baru 46% yang harus dicapai. Tetapi tadi seperti yang saya katakan bahwa menjangkau masyarakat untuk diperiksa atau dilakukan screening kesehatan secara dini itu sudah bagus. Tadi DKI ya sudah 90%, kemudian beberapa ibu kota provinsi itu sudah tinggi cakupan untuk deteksinya, untuk screeningnya sudah tinggi. Tetapi untuk tata laksana ini masih rendah. Memang ini masih masalah dalam akses terhadap penata laksanaan layanan itu sendiri. Nah, tadi saya sudah katakan banyak faktor yang mempengaruhi untuk penata laksanaan. Yang pertama dari manusianya. Kalau dari segi tenaga, perawat terutama kita ini banyak ya, kelihatannya banyak. Jumlah tenaga kesehatan yang paling mendominasi itu kalau bukan perawat, bidan ya. Perawat, bidan itu selalu bersaing di semua kabupaten, di semua tempat, paling itu yang mendominasi. Tetapi dengan tenaga yang banyak ini, terdistribusinya itu belum sesuai dengan kebutuhan. Coba kita lihat data-data tenaga kesehatan di daerah-daerah terpencil, di daerah DTPK. Kalau di kota iya, melimpah tenaga, bahkan lebih. Tetapi sekarang kalau kita lihat di daerah-daerah terpencil itu masih banyak yang kekurangan tenaga. Ya, di Permenkes Peraturan Menteri Kesehatan kita sekarang ini kalau dulu di puskesmas itu minimal 9 jenis tenaga yang dibutuhkan, sekarang bertambah 11. Yang kurang itu adalah psikologi klinis, kemudian laboratorium itu masih kurang. Jadi memang kalau deteksi dini sudah tinggi tetapi pengobatan masih rendah, memang ini adalah masih dianggap salah satu masalah dalam akses ya. Karena sekali lagi akses bukan hanya tentang jarak tetapi akses dari pelayanan itu sendiri, bagaimana kita mendapatkan pelayanan. Ya, jadi ini masih masalah Mbak Vini ya. Untuk di Indonesia ini memang masih masalah dan sekali lagi faktornya banyak, bukan hanya dari tenaga, selain dari tenaga terutama daerah terpencil, dari pengobatan. Pernah loh di puskesmas itu 1-2 bulan itu tidak ada obat untuk mengobati hipertensi. Amlodipin itu sama sekali tidak ada, pernah kejadian seperti itu. Karena kita lihat proses untuk pengadaan obat itu kan tidak bisa, apalagi di puskesmas ya, instansi pemerintah, Tidak bisa hanya butuh obat ini, hari ini langsung pergi beli di apotek. Tidak bisa seperti itu. Jadi proses-proses pengadaan di instansi pemerintah itu ada alurnya. Ada perencanaan di awal, kemudian ada proses lelang, proses tender, apakah itu melalui e-katalog atau melalui apa ya, penyedia-penyedia obat, tetapi tidak bisa langsung, oh saya mau beli amlodipin 1.000 biji mau disediakan oleh penyedia ini, tidak bisa. Itu harus melalui proses, sehingga kalau proses itu terlambat karena kita tidak bisa menutup mata dalam hal pengadaan proses seperti ini, faktor politik itu masih ada, ya. Faktor politik itu masih ada. Siapa bupatinya, siapa pemimpinnya, maka siapa yang akan mendapatkan proyek itu masih ada di kita. Ya, sehingga itu salah satu yang menghambat akses terhadap penata laksanaan layanan ini. Nah, inilah sehingga Mbak Vini mengatakan ini menunjukkan adanya kegagalan dalam desain kesenambungan pelayanan. Betul. Ya, karena memang kesinambungan pelayanan itu banyak sekali faktor, ya. Tadi alat EKG, ya, alat EKG ada pengadaan dari Kemenkes sekarang ini melalui proyek SOPI itu banyak sekali diadakan, bahkan semua puskesmas sudah dilengkapi dengan EKG. Tetapi kembali lagi kemampuan kita, EKG itu kan yang melakukan pemeriksaannya kan perawat. Ya, jarang dokter yang melakukan EKG. Itu adalah pekerjaannya perawat, tetapi yang saya lihat masih banyak yang teman-teman kita perawat ini belum mampu melakukan pemeriksaan untuk memasang alat EKG dan dengan benar, ya, sehingga ya hasilnya ya seperti itu karena tidak terbiasa melakukan, padahal sebenarnya masyarakat yang butuh, ya, 20 sampai 60 tahun sampai lansia ini kan wajib di EKG kalau dia sudah hipertensi dan DM. Kalau keduanya ini sudah ada hipertensi dan DM itu wajib hukumnya. Ya, meskipun dia umur 20 tahun kemudian yang wajib lagi adalah usia di atas 40 tahun. Itu sudah wajib. Kita-kita ini seharusnya sudah wajib EKG minimal 1 kali setahun. Tapi itu lagi, kita akan ke fasilitas kesehatan, ke rumah sakit kalau sudah tidak bisa melakukan aktivitas sehari-hari. Baru kita bilang, oh saya lagi sakit, saya izin sakit. Ya, ya mungkin itu Mbak Vini, mudah-mudahan menjawab. Terima kasih.
Oke, bagaimana? Oh, oke. Bagaimana Mbak Vini? Apakah sudah clear atau ada yang ingin ditanyakan atau didiskusikan kembali? Oke. Oke. Sudah cukup ya Bu Lucy. Kemudian next to the second question from sharing, lebih kepada sharing dari Mbak Nur Hayati dari Poltekkes Banten. Terkait dengan pelaksanaan CKG di lapangan, saya setuju dengan pernyataan Ibu bahwa bukan hanya sebanyak-banyak orang yang di CKG, tapi seberapa banyak masalah kesehatan yang ditemukan dari kegiatan CKG tersebut agar dapat dilakukan tata laksana lanjutan. Namun, kadang kendala target waktu penginputan sebagai tekanan atau kegiatan sudah berjalan, tapi belum semuanya terinput ke dalam aplikasi karena terlalu banyaknya aplikasi dari masing-masing program juga bagi kami yang ada di lapangan atau di puskesmas itu menjadi suatu keterbatasan, ya, dan keterbatasan tenaga, ya, sehingga mungkin apa yang sudah dilakukan tapi belum maksimal dilaporkan. Semoga dapat dievaluasi dan kedepannya semua program yang ada di puskesmas itu datanya dapat diinput ke aplikasi dan saling terintegrasi agar fokus kami bukan hanya pada target dalam penginputan CKG, tapi betul-betul merealisasikan pelayanan pelayanan dengan maksimal kepada masyarakat. Oh, oke. Seperti itu, Bu Lucy. Ada tanggapan?
Iya, terima kasih Mbak. Apa tadi ini? Mbak Nur Hayati. Ya, memang kalau kita di lapangan, apalagi dengan transformasi layanan, transformasi digitalisasi sekarang ini dari Kemenkes, betul-betul teman-teman di puskesmas itu apa ya, sangat sangat dibebani dengan penginputan, ya. Untungnya sekarang sudah ada RME, rekam medik elektronik, dan untuk program CKG ini kemarin ya minggu lalu itu ada Zoom dan ada penjelasan dari kementerian bahwa akan bridging ya akan connect antara aplikasi ASIK CKG dengan RME atau rekam medis elektronik yang ada di puskesmas. Jadi sekarang di puskesmas itu sudah seperti rumah sakit, sudah tidak ada rekam medis manual. Begitu datang daftar, kemudian mau ke poli, bawa ini dokumennya ke poli, kemudian mau ke obat, bawa lagi dokumennya ke obat, mau ke laboratorium, bawa lagi. Jadi itu sudah sistem, sudah seperti di rumah sakit. Nah, setelah itu sudah berjalan, datang lagi nih program CKG. CKG hasilnya dengan target 46% jumlah penduduk tadi, hampir setengah dari jadi seluruh penduduk yang ada di wilayah kerja, hampir setengahnya itu harus di cover, harus dideteksi, kemudian itu di input by name. Jadi satu orang menginput. Nah, sekarang ini karena keluhan ini beberapa aplikasi pengelola-pengelola program juga semuanya pelaporan by aplikasi. Jadi itu betul-betul seperti di puskesmas, teman-teman di lapangan itu melakukan pelayanan, setelah melakukan pelayanan inputnya pun kadang eh, tidak selesai dalam sehari sehingga itu ada hutang untuk besoknya, untuk dibawa pulang sehingga hanya itu yang terjadi, kemampuan menganalisis, boro-boro mau menganalisis, menginput saja nggak selesai, apalagi mau dianalisis ya. Oleh sebab itu keluhan-keluhan ini sudah sering kami sampaikan, apalagi saya di Dinas Kesehatan kalau ketemu dengan Kemenkes selalu kami menyampaikan bahwa tolonglah karena digitalisasi ini kan sebenarnya tujuannya untuk mempermudah, bukan untuk semakin mempersulit. Jadi aplikasi-aplikasi yang datanya sama, bolehkah itu di bridging ya, bisa satu kali menginput, dua program selesai. Jadi untuk CKG dan RME ini sudah ada kabar baik dari kementerian. Kita tunggu saja ke depan ini apakah betul bisa satu kali menginput untuk satu orang. Jadi menginput di RME tidak perlu lagi menginput di CKG atau menginput di CKG karena kalau di CKG itu kan kita bisa menginput di lapangan. Pergi ke komunitas, pergi ke rumah, pergi ke posyandu itu kita bisa menginput di situ kalau CKG. Tapi kalau RME rekam medik itu di puskesmas untuk yang datang berobat di puskesmas atau yang berkunjung ke puskesmas atau screening atau apalah di dalam gedung. Ya, jadi kita tunggu saja janji Kemenkes dan itu kemarin sudah ada informasi dari Pusdatin ya, Pusat Data dan Teknologi Informasi itu mereka akan bridgingkan supaya tidak habis waktu untuk menginput ya. Demikian Mbak Nur Hayati, terima kasih.
Baik, terima kasih tanggapannya, Ibu Lucy. Mungkin saya berikan kesempatan satu pertanyaan lagi pada teman-teman yang ingin bertanya. Masih ada waktu 2 menit. We have 2 minutes more. If you have any question. Sepertinya sudah tidak ada ya. Sudah pas ya. Sudah pas. Oke. Oh, apa ini? Oh, sudah. Oke. Semoga ya, Mbak Nur Hayati nanti kita tunggu sama-sama gitu ya. Baik. Mungkin saya close untuk pertanyaan sesi terakhir untuk narasumber yang keempat pada sesi kali ini. Mungkin saya akan menyimpulkan terkait apa tadi yang sudah Ibu Lucy sampaikan kaitannya dengan praktik yang sudah berjalan begitu ya di komunitas ya bahwasannya community based cardiovascular prevention itu adalah suatu intervensi yang paling efektif ketika itu dilakukan secara komprehensif, kemudian kolaborasi, kemudian bisa diakses, kemudian sustainable dan ketercapaiannya juga bisa diukur. Kemudian tadi kaitannya dengan beberapa strategi ya yang dilakukan tadi itu ya ada screen yaitu dengan melakukan CKG, kemudian educate gitu ya, bagaimana kita memperbaiki literasi kesehatan yang ada di keluarga. Kemudian selanjutnya adalah empower ya. Eh, Harapannya adalah ketika literasinya baik, maka pemberdayaan yang berlangsung di keluarga itu juga akan meningkat gitu ya. Kemudian tercipta engage, dilanjutkan dengan monitoring secara berkala, kemudian ada refer dan ada follow up. Kemudian the future of cardiovascular disease prevention extend beyond hospital. It lies within a family, community, primary healthcare services, and people's everyday health decision. Ya, jadi memang butuh kolaborasi dari berbagai lini, berbagai lintas sektor mungkin ya untuk bisa betul-betul menjalankan kaitannya dengan upaya-upaya promotif dan preventif yang ada di lingkup komunitas. Mungkin itu saja dari saya. We would like to express our deepest gratitude to our exceptional speaker, to all of the speakers, for sharing their invaluable expertise and clinical insight and community-driven strategies with us today. Uh, and I thank all of you, all participant. You have an active participant and insightful question. And as the moderator, I would like to take my leave. My apologies for any shortcoming during the session. Thank you. Stay safe and have a wonderful day. Terima kasih banyak. Saya akhiri. Wassalamualaikum warahmatullahi wabarakatuh. Untuk selanjutnya saya serahkan ke MC.
Baik, terima kasih banyak semuanya.
Thank you to Mrs. Lucina Sampe, MCUP Nurse SP Kepkom, for your excellent presentation, and to Mrs. Yunita Sari, MCUP SP Kepkom, for wielding this session with professionalism.
Terima kasih kepada Ibu Luciana sampai SP Kepkom yang telah menyampaikan materinya dengan baik, serta kepada Ibu Yunita Sari SP Kepkom yang telah memandu jalannya sesi dengan penuh profesionalisme. Please give applause to our speaker and moderator. We will now process to the distribution of the door prize for this discussion session. As part of our appreciation, participants who actively takes part in the discussion will be selected to receive a door prize. We kindly request all attendees to remain attentive as we announce the recipients.
Selanjutnya, kita akan memasuki pembagian door prize untuk sesi diskusi. Sebagai bentuk apresiasi, peserta yang berpartisipasi aktif dalam diskusi akan dipilih untuk menerima door prize. Kami memohon kepada seluruh hadirin untuk tetap memperhatikan saat kami mengumumkan penerimanya. Kepada panitia yang bertugas, kami persilahkan.
Baik, kita sudah sampai nih di momen yang ditunggu-tunggu. Tadi kita sudah mendengarkan beberapa pertanyaan yang menarik dan tentunya menambah wawasan kita semua.
Nah, dari beberapa penanya yang sudah berpartisipasi, ada dua penanya nih yang dinilai paling menarik, kritis, dan relevan dengan materi yang telah disampaikan. Dan untuk mengapresiasi keaktifan tersebut, kami akan memberikan door prize untuk penanya terbaik. Nah, penasaran gak nih kira-kira orangnya siapa? Mungkin untuk mempersingkat waktu, kita langsung aja ya. Baik, door prize penanya terbaik kali ini diberikan kepada Pak Sini Rahma Azahra, Universitas Valeteha. Untuk door prize kedua yaitu diberikan kepada Nur Hayati, Poltekkes, Kemenkes, Banten. Kita kasih applause dulu buat para pemenang door prize. Baik, semoga door prize ini bisa menjadi apresiasi dan motivasi untuk kita semua agar semakin aktif bertanya, berdiskusi, dan berani menyampaikan pendapat. Sekali lagi, terima kasih kepada pemenang dan terima kasih untuk seluruh peserta yang sudah aktif berpartisipasi. Untuk pemenang, silahkan menghubungi panitia di kolom chat ya. Baik, terima kasih. Kami serahkan kembali kepada MC.
Congratulations to our prize winner. We hope you enjoy the gift and wish you all the best.
Selamat kepada pemenang door prize. Semoga Anda menikmati hadiah tersebut dan selalu sukses. Alright, the next agenda item is the closing prayer, which will be led by Mr. Ahmad Rifai. The stage is yours.
Baik, acara selanjutnya adalah pembacaan doa penutup yang akan dipimpin oleh Saudara Ahmad Rifai. Kepadanya, kami persilakan. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Waalaikumsalam warahmatullahi wabarakatuh.
Bismillahirrahmanirrahim. Hadirin yang kami hormati, sebelum mengakhiri rangkaian kegiatan webinar internasional 2026, marilah kita menundukkan kepala sejenak untuk memanjatkan doa kepada Allah Subhanahu wa Ta'ala. Semoga kegiatan yang telah kita ikuti bersama senantiasa mendapat keberkahan dan memberikan manfaat bagi kita semua. Alhamdulillahirabbil alamin. Ya Allah, Tuhan yang Maha Pengasih lagi Maha Penyayang. Kami panjatkan puji dan syukur kehadirat-Mu atas segala nikmat, kesehatan, kesempatan, serta kemudahan yang Kau berikan kepada kami, sehingga kegiatan ini dapat terlaksana dengan baik. Ya Allah, Tuhan yang Maha Mengetahui, berkahilah ilmu dan pengetahuan yang telah kami peroleh melalui kegiatan ini. Jadikanlah ilmu tersebut sebagai ilmu manfaat yang dapat kami amalkan dengan penuh tanggung jawab dan menjadi bekal untuk meningkatkan kompetensi serta memberikan pelayanan yang terbaik bagi sesama. Ya Allah, kami memohon keberkahan bagi para narasumber, panitia, dan seluruh pihak yang telah berkontribusi dalam terselenggaranya webinar internasional 2026. Balaslah setiap waktu, tenaga, dan ilmu yang telah diberikan dengan kebaikan, kesehatan, serta keberkahan dari-Mu, ya Allah. Ya Allah, bimbinglah langkah kami agar senantiasa memiliki semangat untuk belajar, berkembang, berbagi, dan mengabdikan ilmu dalam bidang keperawatan. Tumbuhkanlah dalam diri kami sikap profesional, kepedulian, keikhlasan, dan rasa kemanusiaan dalam setiap pengabdian yang kami lakukan. Ya Allah yang Maha Pengampun, ampunilah segala dosa dan kehilafan kami, dosa kedua orang tua kami, para guru dan pendidik kami, serta orang-orang yang telah berjasa dalam kehidupan kami. Limpahkanlah rahmat dan kasih sayang-Mu kepada mereka. Rabbana taqabbal minna innaka antas samiul alim wa tub alaina innaka antat tawwabur rahim. Ya Allah, kabulkanlah segala doa dan harapan yang kami panjatkan
Berikanlah kepada kami kebaikan dalam kehidupan dunia dan akhirat. Pertemukanlah kami kembali dalam kesempatan-kesempatan yang penuh keberkahan dan kebaikan. Amin ya Rabbal Alamin. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you to Mr. Ahmad Rifai. May our prayers be answered by God Almighty. Amen.
Terima kasih kepada Saudara Ahmad Rifai. Semoga doa kita dikabulkan oleh Tuhan Yang Maha Esa. Amin.
Ladies and gentlemen, we have now reached the end of today's event. We would like to express our sincere gratitude to all speakers, participants, and everyone involved in making this event successful. Thank you for your attention, cooperation, and active participation throughout the session.
Hadirin sekalian, kita telah sampai pada akhir rangkaian acara hari ini. Kami mengucapkan terima kasih yang sebesar-besarnya kepada para pembicara, peserta, dan semua pihak yang telah berkontribusi dalam menyukseskan acara ini. Terima kasih atas perhatian, kerjasama, dan partisipasi aktif Anda selama kegiatan berlangsung. Sampai bertemu kembali pada acara kami berikutnya. Selamat beraktivitas dan tetap jaga kesehatan. As the event host on behalf of the organizing committee of the International Nursing Webinar 2026, we sincerely apologize for any words or action we have might taken.
Kami selaku pembawa acara mewakili kepanitiaan kegiatan International Nursing Webinar 2026 memohon maaf sebesar-besarnya apabila ada kata atau perbuatan yang kurang berkenan. We are thankful and appreciate always and participant in this agenda. We do apologize for the mistake we have made.
Kami mengucapkan rasa terima kasih dan apresiasi kepada seluruh tamu undangan dan peserta pada agenda kali ini. Kami mohon maaf atas segala yang telah kami perbuat.
We, as the Master of Ceremony for the International Nursing Webinar 2026, would like to say thank you and see you later. Wassalamualaikum warahmatullahi wabarakatuh.
So for everyone,
Waalaikumsalam warahmatullahi
Waalaikumsalam warahmatullahi
wabarakatuh.
for
wabarakatuh.
everyone, please attention. We kindly request all participants to on their camera if possible and remain on screen for a moment. Our committee will capture the documentation shortly. Please stay in position until we confirm that the documentation is complete. Thank you for your cooperation.
Kami mohon kepada seluruh peserta untuk menyalakan kameranya jika memungkinkan dan tetap berada di layar sementara waktu. Panitia kami akan melakukan pengambilan dokumentasi beberapa saat lagi. Mohon tetap dalam posisi hingga kami memastikan bahwa dokumentasi telah selesai. Terima kasih atas kerjasama Anda.
Baik, mohon maaf Ibu, Bapak, dan teman-teman semua. Kita akan melakukan dokumentasi ya. Mohon untuk on cam terlebih dahulu. Kita mulai dari slide 1. Selanjutnya slide 2. Selanjutnya slide 3. Selanjutnya slide 4. Selanjutnya slide 5. Selanjutnya slide 6. Slide 7. Slide 8. Slide 9. Slide 10. Slide 11. Slide 12. Slide 13. Slide 14. Slide 15. Slide 16. Slide 17. Dan slide terakhir. Oke, sudah. Terima kasih Ibu, Bapak, dan teman-teman semua. Okay. Thank you, everyone, and see you later.
Bye.
Recording stopped.